When I started working on this, as a neurologist, I could make a neurology course out of it and absolutely bore you to tears. Or I could teach neurology as it applies to you in your office and how you can use it. I like to teach seminars where you can go in your office Monday morning and you can use something that I taught you. So I'm going to give you the understanding of generally, you've all had neurology, so I don't have to worry about all the picky things and what cell does what so much. You can go back to your neurology book to get further things. You couldn't teach proprioception system in 3 hours. So I've got to consolidate it, bring it together, and primarily get it to where you understand it, and you can get it to work for you. The basis, basically, is what we do. It's what we have, what we treat. Activation of specific sensory nerve involved posture and movement of the body part, pressure, touch. Vestibular sense of balance, horizontal feathers, gravitational field, on and on. Primarily, what we're going to deal with is response of a sensory system. No sensory system is worth anything if you don't stimulate a response. And we're going to talk about the modality, the type of nerve receptors. We're going to talk about location, how specific the location is, the intensity of the stimulation, and then we're going to go to duration, because that is also an important factor. So what is NER? The cognitive mobile structure consisting of billions of cells of multiple types, capable of multiple functions to exist for extended periods. It's a computer-like system, CNS, for cognitive function and coordination of a fuel system and locomotion on demand. Number 2, an organ system for cellular metabolic demand and a locomotive system for hunter-gatherer activity to maintain all the above. And I basically put those in order of importance. Obviously, you can have, as long as your computer works and as long as you have an organ system to provide the energy, the locomotion is not going to matter that much except for the hunter-gatherer aspect. Cranium houses 80% of the nervous system, the computer system, in bone. At its highest point with the greatest range of motion, sensory input, except 20% is outside the cranium for joint motion control and metabolic support of the organs. Now, I can't overemphasize the importance of the central nervous system to the body. Number one, the central nervous system has its own circulatory system called CSF. The CSF is so important that it has a blood-brain barrier to filter out any pharmaceuticals that the medical industry tries to put in there and screw you up. So we filter it, and then we got to get it to pump. Now you have to understand that the central nervous system, the brain, on the average, they say, consumes nutrients at a ratio of 7:3 to the other cells of the body. It is the greatest demanding tissue in the body. It works 24/7. Always. You can rest the muscles, you can rest the organs, but you can't rest the brain. Many of you know that at night sometimes when you try to go to bed. So, the biggest thing is you've got to keep that central nervous system going. And the rate of function, or the metabolic activity of that brain tissue is going to be dependent upon whether it has available those chemical constituents that it needs to be able to have a chemical reaction. The biggest thing is glycogen, and the next thing is oxygen. Those are the two main components. Not that all the rest are important. But everything, and when it has a problem, it makes the rest of the body work like crazy to try to get rid of it. You can just move over one seat, and then you can sit there every damn time this thing goes back, they just shove it back over on something, okay?
Okay.
It's a pain in the stuff.
Thanks.
Okay, so The most important thing is that brain. And that you just have to understand the consumption of nutrition and oxygen and et cetera that it uses. Now, it's very interesting because in uterine, the nervous system is the first thing that develops in uterine. And it starts on the third day after conception. And it starts with the neurological system. It starts creating nerve pathways. Once the nerve pathways become established, then it starts building the somatic system. When it does, one of the first things that occurs is the heart, because it has to be able to pump nutrients to the somatic system. So how do you pump nutrients through the nerve cells to start developing in the third day? You have to have a metabolic activity in those cells, and so osteopathically, the only thing they could determine was that there was glial cells that actually had a contractile rhythm, which we call the CRI, rhythmic impulse. And this is the basis that it goes on pumping CSF, or pumping nutrients through the body, through the nervous system primarily, into a border. Well, when we're in uterine, the demand on the central nervous system remains relatively consistent. So the CRI, which is around 12, 14 pulsations a minute, is fine. But then all of a sudden, we're brought out into this world. And of course, they always show that we hold the baby upside down, slapping him on the sacrum, to be able to start the sacral, cranial, respiratory motion. Now we've got diaphragmatic motion. Diaphragmatic motion is greater by volume, and it is variable. And so as long as you are being able to maintain the oxygen level and glycogen level in the brain, that's what maintains it. All right, so this is basically what we're going to be working with. That is what encloses the central nervous system. And it's interesting because the whole central nervous system is enclosed in bone. You can't get to it unless you have a drill or a saw. That's how important it is. So it's got its own circulation system. It's got a blood-brain filter. It's got its own pumping system. And it's enclosed in bone, so you can't screw it. I think that pretty damn tells you how darn important this thing is. Of course, as chiropractors, all we do is worry about the hunter-gatherer. Primarily what we're going to be talking about is we've got postural and volitional muscle. Postural muscle is primarily, that is going to be the main emphasis we're going to have in proprioception, because we have to be able to maintain this pumping ability of the cranium and the sacrum, and be able to maintain that pumping and get the oxygen and glycogen to the brain, central nervous system, and at the same time play football, fall on your roller skates, have car accidents, etc. But these are the muscles primarily. Now, you'll notice that down here, this is purple. Then that's primarily because we have both voluntary and postural muscles mixed together.
Not supposed to tap.
No, it just, come on. There. So, all of you know that any sensory information, on one side we have the ascending tracts to bring information up to the reticular formation at the base of the brain, and then we have descending tracts to bring it from there down. It goes up to the base of the brain. The base of the brain, reticular formation, and the pons and then the medulla, is the computer system. So a computer isn't any good if it doesn't have input. And so that's where the tracks are. And that is the main thing. That is constantly going on to maintain us. However, when we really get looking at this thing, number one, it takes time to compute. So when you have an input coming in, it takes a little time for the body to adapt. So you have to have a first line of response. And that is called the propriospinal system, which is right here. And that is the fast react. That's the simple spinal reflex. That is, as soon as you do something, boom, it happens. In the meantime, the same message is going to the brain to be computed with the vestibular mechanism, with hearing, with visual, with all the other things, including the propriospinal system or proprioceptive system of the upper extremity, which we will get into in a minute. So we have a three-tier system, and as you know, you have three nerves going up to the brain and three nerves coming down. So the first one we have is a simple spinal reflex, and then you have the propriospinal system. So you can get a reflex in from the nerve root, but it also goes into the propriospinal system. That information goes up to the brain for integration, particular formations, cerebellar, hypothalamus, etc. From there, with repetition, it gradually goes in, and we call it plasticity. It goes into the neocortex, the thalamus, the basal ganglia. Now we store it. So we've taken the information, and if you do something long enough, pretty soon you facilitate that nerve impulse, and it stores it and becomes plastic. It actually sends on little neuron, little feet to make the connections to the nerve cells. And this is not a short term process, it's a long process. Now, when you get talking about nerves, and this is why I said I'm not going to teach you a neurology course, I want to teach you how, who cares? You know, we got nerves going in, we got nerves going out, we have multiple receptors. It gets to be a real bloody zoo. One other thing that I find people think, they think, oh, well, that nerve. Well, there's a nerve. And look how many nerves are within the nerve. You have fibrils, you have fibers, you have neurons. I mean, you've got all different sizes, not just one nerve. Any nerve is a trunk. Multiple nerves inside. Some fast, some slow. But it's constantly firing, and it channels it and it protects it. That's why you have myelin sheath, so that you can't. So everything goes into nerve tracts, nerve pathways, into nerves, but not the little tiny fibrils. Matter of fact, many of the nerve fibers that you're going to be stimulating, when you do surgery, you can't even see them. And then you get all the interconnections. And let me tell you, there are interconnections. As you can see, you've got them on the body, you've got them on the axon, you've got some that are telling the cell to slow down, you've got some that are speeding the cell up, you have some that are Raynaud cells, which are constantly keeping an impulse at the same time. But this becomes totally gross. And to try to get into this, who cares? You got a patient that's in pain, you got a patient that's got a heart problem, you got a patient they can't think, an ADD kid. You can't be worried about all the stinking individual little nerves in there. You got to look at the general overall plan. Matter of fact, it's interesting. A book I read at one time, and it was written by some PhD, and it was basically based on chiropractic, or into that direction. And what he was mentioning was how much medical research they keep taking apart the atom further and further and further to where they lose the whole context of why they were even bothered to take the thing apart in the first place. How does this little tiny portion relate to the very whole? So I'd rather go back to the whole and relate to these things down here, but I want to relate how one thing affects the total thing, not how all these little things work. That's great in a neurology course, but that don't help on Monday morning. And again, I sat and looked at these things. I can remember when I was in a neurology course trying to understand all this stuff. It have anything to do with anything. And then we get into the, Dan, can we just dim down the light a little bit? Can you see that screen okay? With these leopard lights here?
If we do, we'll lose you.
Huh? Whoop.
I may lose you.
Oh my goodness. Can you see me?
I can see you, but you look like you got another
All right, well, that's,
African
can you see it all
American.
right?
A little African American. They should be wrist pad on.
This one does those legs.
Oh, okay, yeah, keep them doing.
All right, well, now you. Whoop. Okay. So anyway, the biggest thing you want to understand is the fact that there is just tons of stuff feeding into the spinal cord. And as we went before, and we told you they go into the tracts, ascending and descending tracts. But they also, when they come in, before they go into the ascending or descending tracks, they also work nerve-wise and not at a particular level. Matter of fact, all of you probably remember the fact that at a nerve level, the nerve coming in that spinal cord level, it goes up 3 levels up and 3 levels down. So we have, and it's probably more fan-shaped. It's like this, concentrated in one area with lesser going the further away you go. But that's the nerve-free reflex. That's why it's really hard to say, well, this is for L5 or 12, because L4 is going to affect the L5 nerve, etc. So you've got to be able to work with that too. But the main thing I want you to understand is just a lot of stuff going on here over. And the systems work together. It's just like, you know, how much proprioceptive difference would there be in a reaction in touching a hot stove, in being able to stick your finger or cut yourself, or in rubbing your hand, or motion. It doesn't matter what it is that stimulates it, you're going to be able to react. And it's probably going to be a combination of all. It's just like we know we have superficial receptors in the skin. Then we have deep receptors. Then you got joint receptors. So the more pressure you apply, the more nerves you're involving, which we'll go into in regard to doing nerve reflexes. So again, the main thing that we want to talk about is what we're looking at is a patient that's coming in who's got a lot of stress, a lot of problems in being able to function. And it's to a point to where it's starting to max out their ability. And what, you know, I tell my patients in the office, I always talk to them about the toothache and cavities. You know, by the time you get a toothache, you hope it's only a root canal, not an extraction. The main thing I want them to understand and explain to them is that by the time you get a symptom, the symptom is the body being maxed out. There's no more place to go, and it's saying, I ain't got no more room. And so I tell people it's probably about 80% of you. You know, you can tolerate a lot. When you stop and you look back at your life and what you've done and how you beat yourself up, it's a damn wonder any of us live as long as we do. But the body is a tremendously absorptive, compensatory type of organ. But you have 80% of that problem by the time you get the symptom. That's why in SOT, being able to use the indicator system, the proprioceptive indicator system, is the greatest thing for patient education. Because if you can get them to understand, I have patients that come in and they say, Doc, my stomach's off. Or they say, you know, I think my sacroiliac's off. Or they'll go up there and they say, geez, my ankle must be gone. I mean, they know where I'm going to go to find a lot of the things that I find. And they know what it is because I get them involved and they get all excited about it. Now, you know, I see a lot of people, I see a lot of teachers at Sorcy teaching how to do an arm faucet test. And they're very careful to touch. They don't want to hurt the patient. And they'll touch out here in the bone where there's no receptors. They're touching into the inguinal ligament or into the ligament. To be able to stimulate enough receptors. Okay. Speak loud. All right. So, you've got to be able to fire receptors to get a neurological reaction. And so with that, there. So, to start with, we have nerve tone. You know, when they talk about ball players, they send them out to warm up. Temperature's got nothing to do with it. What they do is they send them out there to start firing nerves. You start increasing their neural tone. You start bringing. No, not there.
Oh, sorry.
Oh, I didn't know you were both doing the same time. There we go. You know, we have a weak stimulus. When you get up in the morning, you're sitting, your nerve reflex is sitting at the rest of the body. Well, you get up, you start walking around, and so the nerve metabolic activity the nerve metabolic activity raises a little bit. So then you go out, and now you want to go out and you warm up. We raise that metabolic activity at nerve level so that it can fire to the point of fire. It has to reach that threshold. To do that, it's going to depend about how many impulses you put in to be able to fire a nerve. Let's see, maybe like this. You know, when you have a nerve, you have a receptor, you have a nerve and it goes to the cell body, and then it goes out. And then you have the nucleus. You've got to fire this receptor sufficient enough to get to here, to the focal point of the nerve. This has its own threshold. You've got to fire and hit this hard enough to where it has its chemical reaction and sends that nerve impulse to the end of that nerve. That impulse has to be strong enough with other impulses to go to the next nerve. So you're talking about an accumulative collection of thresholds of receptors to be able to get a neural response. If we were all super sensitive and you could touch just any one and you'd fire, we'd be in trouble. So it takes a number of them. That's why with an arm fossa, you don't use one finger, you use as many fingers as you can get. And Dave Jurnett used to talk about bending your fingers like this so you had 4-finger contact. There's that many receptors you're firing. And then he used to have you do that because that way you would go in behind the inguinal ligament and be able to hit the nerve. Or the receptor. All right, so it takes a good bit. Next thing, sometimes it takes multiple. This may be two superficial receptors. You may not be, just as a matter of fact, it's interesting with the acupuncture. Have any of you taken acupuncture courses? It's really amazing when you take that acupuncture needle, everybody was like, oh, I don't have a sticker needle in me. Never felt it. It is that small. It is so small that it is only hitting one receptor, and it's not enough to fire the pain response. Really interesting. So it takes more. So it's not just, and these have to be specific ones, it has to be sufficient, it has to be enough, and it has to be long enough. You can't just do that. The body has to know that it's in trouble. So the whole thing with proprioception is the degree of firing. In the office, we know trapezius, gluteal indicator, cervical indicator, whatever you use. The degree of contraction and reactivity sure tells us how bad the problem is, doesn't it? And just because it's not severe doesn't mean it doesn't exist. Sometimes you have to be really sensitive to be able to feel the differences. But you will find that these proprioceptive balances are important, and you can read them. You can tell the degree of. If I check and find somebody with a trap 3 trapezius and a gluteal 1 gluteal indicator, which one am I going to use to determine whether it's an upper or lower subluxation? The one that hurts the worst, because it's the biggest part of the proprioceptive system that's involved. Now, proprioceptive system, input for posture, action function, and computer brain. We're going to talk about the first response, the initial fight or flight, because that initial response is what the rest of the proprioceptive system repatterns and rebuilds into its plan, and then plasticizes if fired often enough. So, we're talking first response. We're going to talk lumbosacral plexus, brachial plexus, work together. We're going to explain why. Trigeminal spinal nucleus, the cervical spine and the cranium. work together.
Nelson, do you want to set that on the slideshow and make it bigger?
It won't stay there. I'm having a bitch for time. Try it again. There. So we have two systems here. Now we're going to explain it. Oops. All right, come on. There. And it was interesting because this is out of an old book that I had, diagram of somatic sensory systems. Number one, it had the trigeminal, brachial plexus, lumbosacral plexus. And I thought, well, that's interesting. And then I got thinking about it. And it made sense that those are the major areas of motion the body has to maintain. So we have those three. Now, number one, we have the cervical cranial proprioceptive system. The cervical muscles, maxillary muscles, or muscles of mastication, are constantly working to be able to maintain cerebrospinal fluid function. It's monitoring that spinobasilar joint to make sure that you've got full respiratory motion and pumping of cerebrospinal fluid. So it's going on all the time, no matter what you do with the rest of the body. That has got its own objective to do right there. Its objective is to maintain cerebrospinal fluid flow. The other thing we've got is being able to carry this simple entity up here, or entity within itself of constantly maintaining cerebrospinal fluid, being able to carry it around and go places. So now we have the propriospinal system. The propriospinal system goes all the way up to C1 and all the way down to the feet. The propriocervical cranial is the cranium down to C2.5. All the upper cervical nerves attached to the cranium are innervated by C1 and C2. The area between, the area of integration, this is the area where now the reactivity of the cervical cranial balancing to maintain CRI, and be able to maintain respiratory function of the cranium, is using the upper cervical muscles, C1 and C2, which are firing. And with the propriospinal system, anything that's going on at C1, C2 is also firing all the way down the spine. So now when this starts getting stressed beyond the point to where the cranium is able to maintain cerebrospinal fluid flow at the rate of demand and needs help, now the propriospinal system starts to vary, to adapt, to take the stress off the cervical cranial system so that it's better able to deal. Capiche? At the same time, and we'll get into this, anything that goes on down below, the body can try to balance itself, but then once it does, it's going to have to maintain our visual balance. So as this keeps trying to balance, now the cervical cranial system can balance to whatever this has to adapt to. I hurt my low back. I'm standing this way. It's going to take, the change is going to be up there in C1, C2 to be able to keep the eyes up. C1, C2 also handles the motor going into the cranium. So if you're now controlling the occiput with the suboccipital muscles, now through the trigeminal nerve you're also controlling the muscles of mastication. So now you're getting a torquing to adapt to the low back L5 disc or whatever. Questions? Okay, so first response system, propriospinal, all sensory input below the cranium. Propriocervical cranial system, all input down to C2.5. Area of proprioceptive integration, C1, C2. Put that button. Enter.
Enter?
No.
I'm sorry.
That one.
I went too fast.
No, I noticed when I did this before, this stayed there, but all I had, when it goes back, this arrow stayed right where it's supposed to be.
Mhm.
Lovely. All I had to do was tap it.
I got it.
I'm not backwards. Took me, I don't know how many times I've used that to teach me. Okay. All right, so the area of proprioceptive integration, C1, C2. And we're going to go through this because I wrote a paper on this a number of years ago, Advanced Cervical Diagnosis and Treatment, in which I went in and described the specific type of manipulation or specific type of motion at the occiput C1, C1, C2. You do not adjust C1. You don't have to. It's too easy to respond without. With that. Okay, so we're going to start above. Okay, what would you say are our primary areas that the body is necessarily concerned? Number one would be the spina basilar. The spina basilar is the axis of all the motion. Also, the spina basilar area, what's right above it in the brain? Hypothalamus. All your organ function comes from that area right above the spina basilar, which hopefully has got some motion to be able to keep the circulation going through there so you don't have a decrease in metabolic activity in the hypothalamus. So that is the area. Now, we always talk about fixing the temporal bone and the maximal and all this, but why are we fixing it? It'd be no different than fixing the ankle and the knee to take the pressure off the low back. Where's the importance? The low back. So what we're looking at primarily is we're trying to focus on being able to balance that spina basilar area. And that's going to take, well, we'll go into the motion. Okay, so with the primary respiration, and this is where the osteopaths, what the CRI is what's established in uterine and started with about the third day. And this is what pumping of the metabolic activity for the cells in their established body. And this goes on through life. And it's got a torsional eddying effect, counterclockwise. This goes down the bottom. But it's only about 12 to 14 motions, and it's very slight. You can feel it. When I teach seminars, I have people put their arm on, put their hand on their arm, and I have them focus on feeling the pulse. Now, I don't look for blood vessels, put your hand on there. And you can feel pulse. Then I have them say, okay, now breathe in and out deep and feel the pulsation that goes with the heart, with the respiration. All right, now ignore that and just feel, you'll feel a slower movement, about 12 to 14 times. Just kind of an eddying flow. See that? So that is it. It's throughout the whole body. So we have that motion, and the osteopaths feel that that is probably a glial cell contractile type of situation. Diaphragmatic, respiratory, anterior. Okay, so now we get into the major pump. This is the big guy. This is the guy, this is where you're going to get sutural motion. This is where you have intra and inter cranial motion. Intra is sutural. Inter is bone flexion. It's interesting when you look at the spine, we have two kinds of bone in the spine. You look at the body, and that's a compressive spine, that's a compressive type of bone. Back of the vertebra is very hard bone. That's a bending, flexing bone. So we have two different types of bone. So you can make bone to do whatever the job is. When we look at the spina basilar area, the spina basilar area is quite large. It's compressible. And so a lot of the flexing comes with the compressibility of the two bones. So When we talk about suture motion, we're talking about actual flexing of the bones itself as well as the sutures. Now, I'm sure that all of you can imagine, and I've got some slides from Uplift, as a matter of fact, that shows nerves in the sutures and blood vessels in the sutures. There's living tissue in the cell, in the sutures. They have nerve receptors. That is going into the proprioceptive system. Dural membranes. Obviously, a dural membrane is going to have some receptors, some fibers in there, to be able to send out an impulse. If you stress it, if you do any movement or stress into that tentorium or the falx cerebri, you're going to have a neurological reaction. Either at its attachment and or any fibers that are within there which are getting stressed. And a lot of these are just simple nerve fibers. Nerve fibers. So when we get on the inside of the cranium, on the inside, the dura, underneath the tentorium, the periosteal tissue, everything that is in there underneath the tentorium is innervated by C2. Some say the vagus, depends on what textbook you read, but the thing is that C2 nerve comes down following the vagus nerve, so they have a hard time determining which one. Depends on which textbook you read. Everything above the tentorium and anterior, forward fossa, middle fossa, posterior fossa C2, this is trigem. All the connective tissue, all the tissues that are in there refer anteriorly into trigem, posteriorly C2. Blood vessels, all the connective tissues, all have receptors. You have a tremendous input of everything coming down and coming into the proprioceptive system. On the outside, you can read it for yourself. Everything here is trigem. Everything here is upper cervical. And so it goes right back in to the trigeminal nerve to be able to balance one end of the sphenobaselar motion to the other end of the sphenobaselar motion. You also have muscle attachment to the base of the skull. Interesting, there's only two muscles that actually end up, the splenus capitis and the sternocleidomastoideus, that actually go to both temporal and parietal bones. Others either go to the temporal bone or occipital bone. So you're getting input. It's interesting because those of you that look at neurology, the sternocleidomastoideus, depending upon what parts you want to talk about it, the lower parts are innervated by different nerves than the upper parts. And it's interesting because even in dental, the way the jaw, whether it retrudes or extrudes, is dependent upon which area of the temporalis muscle is in spasm. So it may be getting a sensory reaction from here. It could be getting a sensory reaction from there, which is why it's either here or it's back here, causing the jaw to go back or forward or up or down, whatever. But you have a way to get multiple input. Other than that, everything is individual bone and monitors that individual bone's motion. Now, all these muscles are innervated C1, C2 from the cervical cranial proprioceptive system. Now, I did a paper a number of years ago on the upper cervical spine. it was interesting. I had some patients come in and you can adjust me, don't adjust my neck. Well, you got to adjust the neck. So I got really taking some time on this thing, trying to figure out how I can go about doing things. And it was very interesting because as I read it, most of this I got out of the Borg and Borg. These are two Swiss neurologists over in Switzerland, who plays B for Swiss. And they took this thing apart. They did X-ray studies of it, etc. And it's very interesting that the motion between occiput C1 is a gliding motion, anterior and posterior. And because of the dens, it can't go, the C1 can't go anywhere. It stays right there. And you also have little ligaments out here that come off. Here's one here that lock it. So all you can do is move the occiput anterior, posterior, and lateral glide. There is no rotation between the occiput and C1. There is only anterior, posterior flexion and lateral glide. There is no rotation. It will not allow it because of these ligaments right here. Rotation comes between C1 and C2. That's why there's an odontoid process, so that it can have something to rotate around. Pretty good idea. Damn nice mechanics. But you have to understand, I'm an engineer. That's my first degree. So I kind of look at things kind of amazing. How did bloody things work? This guy was a genius at this. A lot smarter than I was. So anyway, there is no rotation. It's all lateral glide and anterior posterior movement. All rotation comes between C1 and C2. And when you rotate, you get lateral flexion and rotation from the C2. That's where the motion comes. So let's look at the trigem again. And all I can tell you is that this is probably one of the most important nerves in the body. And I say that because this right here is what protects the sphena basal. This right here is your primary protective entity for cranial sacral respiratory motion. That's what keeps it safe and what keeps it mobile and functional. And it's very interesting because you will see that it also has interconnections with a lot of the other nerve nuclei. As I said earlier, you got to understand, ain't nobody in here working on his own. Everybody is sharing all duties with everybody else to one degree or another. So nothing is just only this. And that's where I showed you those nerve roots. Nerve root is not a nerve. A nerve root is a multiple fibers, neuron. Some are myelinated, some are not. Some are fast, some are slow. All kinds of combinations. And matter of fact, it's interesting. The quick response that I talked about with the propriospinal system, as compared to the propriospinal system that coordinates, that goes right straight up to the basilar portion of the brain, that is 3 times slower than the initial response. So the first thing that happens quickly is your first response, propriospinal. Then while that's happening, 3 times slower is the posterior tracts going up to the brain to create a response. When you get a stimulation from the propriospinal, and we'll talk propriospinal, because that's the main thing we do, and whether you refer to that as propriospinal, propriocranial, cervical cranium, either one you want to talk about, the whole thing. It's that first response, and how strong it is, how often it is, how much there is, where it is. You may have a response that it fires and you know you were there. You know, it's interesting. You got a carpenter carrying the door, and he stubs his toe, and he just keeps right on going. Well, he gets down a ways, and now he hits something bigger. Whoa! He starts to really lose his balance. And in doing so, that hand, that side that tripped, drops. Matter of fact, he may drop the door. He walks further and he hits a big rock. Boom! Or hits a step. It's enough to fire into that system so hard that not only does his knee give out, but the arm drops and he falls. And you can think of various times that you have experienced trips and falls. See, this is where the old people have a problem. You've seen these old people around Florida, walking like this. How many receptors you suppose are being fired when they do this? Damn few. How increased rate of metabolism are those that reflex? Very low. So, the more activity, the more you fire and come up, the better off you are. If you can't fire enough receptors, and it's just enough that you lose and you trip, and you don't have any coordination and reflexes to protect yourself, that's where these old people fall and hit their face and their head. That's why they break hips. Well, that's what they're doing. So anyway, this is probably the most important area right here. But you've got to understand that this thing all works together. Okay, propriospinal system. We talked about the cranium, so now we'll talk more. And like I say, everything that's on everything that is going on, cervical cranial proprioception, all involved at C1, C2. So this is an area that we have to really function. And we have to be able to understand and how it works so that we can be able to break the patterned movement of plasticize. We want to break that reflexing so that it can reestablish a new reflex pattern. If I adjust something in the low back and it takes the stress off the C1, C2, counterbalance, if I don't go up and break this reflexing pattern, then this is going to recreate this. If I adjust the low back or the sacroiliac, and I don't treat this, I don't treat mastoid occipital suture, I don't treat the anterior aspect of the posterior imbalance by releasing the zygoma maxillary dental occlusion, dental bite is going to recreate the suboccipital and is going to recreate the low back. So now we're not going just to correcting the patient. Now we need to get into rehab. Because rehab is refiring and develop plasticity into the new attitude, postural attestation we want to have. But you have to increase the facilitation of those nerves often long enough. It's just like in advertising. In advertising, they know that they have to repeat a name or a slogan. We see it, we hear the song. It has to be 3 times. 2 times won't work. It takes 3 repetitions to sink into the short-term memory. Then it's a question of how many times do we repeat the same thing so you keep firing the short-term memory into permanent memory. And how many of you can sing a song that you heard from a commercial so many times you're sick of it? I mean, you remember, you've heard it, and that's the idea. So in order to create the permanency, the plasticity, to be able to rehabilitate and reestablish the normal function, you've got to be able to fire the proper nerve impulse. To do so, you've got to fire and work within a syndrome. Understand, anything that happens, there is an adaptive syndrome from the top of your head to the bottom of your feet. And if you've got 10, 15 things going on, balancing, and you fix one, you want to guarantee that the other 15 ain't going to recreate the thing you just tried to fix? So now you have to be able to ask the way.
Sorry,
Right.
I fired you quickly.
Okay, so now we're going to get into it. We're going to be talking, again, we're trying to talk overall, but how the overall works. And so now we're going to go into being able to establish patterning. So with the CSF pumping, we know that one thing that has to occur, we know the occiput has to balance with the damn sacrum. Anything that happens to that sacrum is going to have to counteract or counterbalance in the occiput. And so you do something in the sacrum, it focuses up, goes through the spinal cord, hits that C1, C2, C2 area, creates a change, that goes into the occiput adapts and goes into the muscles of mastication to maintain, and then it's got to try to work cervical cranial proprioception to try to balance to this thing down here. So you can see how the whole program develops. And so you have to understand, if you have a dental extraction, you get a blow to the face and you break a cheekbone. Suppose you get a blow onto a cranial bone sufficient enough to create ankylosis of a suture. Now that's pretty hard to do. But if you create a trunk and the muscles contract right there to stabilize, to keep it from irritating, then you can have enough compression that you can also gradually cause degeneration of that joint, that articulation. Now when you try to go back, now you've got to restore normal function. You've got to wait. Now it takes time because new blood vessels have to grow, nerves have to reestablish themselves. This is a time frame, just like with a stroke patient. You don't do anything with a stroke patient for 10 days. It takes, on the average, it takes 10 days for the local areas, capillary fragility, and all this other stuff, to be able to heal to where you can start going in and doing something without disturbing and breaking up the continual metabolic healing factors. You have to wait for 10 days. So, that's important. Obviously. All right, so when we get down to the sacroiliac joint, or pelvis, or sacrum rather, this is probably my favorite. Very interesting. When you go home, I would get your spine, and I would look at it, and if you will look, if you will look at this articulation, don't worry about the movement. Look at this articulation. It's almost like where your humeral head goes in. It's actually almost a socket. On some people, or in some skeletons, more so than others. That is the main fulcrum area right there. And that allows, when you stabilize that S1, that allows the bottom part of the sacrum to be able to go anterior and posterior, or whatever it has to do to maintain motion. Not only that, but this has to be stable enough, strong enough to hold the whole weight of the spine and the body, and in some people that's a tremendous chore, just to be able to hold it there so this can do that. These significant sclerosing at that S1, S2. That tells you you've got a distortion, a torsion, or some kind of a lesion, creating a torquing motion, a continual irritation and inflammation. Because sclerosing, anytime you have irritation and inflammation, there's more calcium in there. It's like putting more cement into the concrete to make grout. For those of you that know anything about construction. But if you watch, you'll notice that sacrum, you look at those joints on that S1. And let me tell you, those are some solid joints. When they get in trouble, you're. So, needless to say, let's look at this also. Number one, this is probably the greatest weight-bearing structures in the body. You've got the whole weight. In the meantime, you've got to like 100-pound bags of feed. You've got to play football. You've got to fall on your backside. You've got to do a lot of things. So it's got to bear weight. And at the same time, it's got to breathe cranial sacral flexion extension. So it's got to do two things at one time. I can't even begin to tell you how many nerve receptors you suppose it requires. It's going to have one set of electrons going that are going to maintain flexion extension. It's going to have another group, weight bearing. So it's having to sit there and do two things up here at the same time. So you got to look at both ends of it. That's where, as I will show you later, we will go into being able to do the arm test to determine respiratory motion. Or you overstress ranges of motion, create aberrations of stress. Or if it's an osseous lesion, now you can also differentiate whether it's an osseous or whether it's respiratory. So you have a decision. Because you got two things going on. Which one is which? Unfortunately, in SOT, the only thing that's major stressed, mainly because most people don't read his book. When he first put out the SOT books, he said sometimes you have to adjust the SI joint. And he showed how to adjust the sacroiliac joint. And then a handful of people, they don't like to adjust. So they got out to where nobody adjusted the SI. Oh, the only thing you do is block it. No. You got two things that go on at the same time all the time. You can have a lesion with both of them. If you just want to fix the respiratory one, well, fine. The patient can go somewhere else and get the other one fixed. But you got two things going on at the same time. And these are greatly neurologically connected. Just like I said, the first response is the main response. Okay, go outside. So, the thing is, with the main proprioceptive system, where we can fire into the posterior tracts, and they go up to the up to the reticular formation, all those tracts, that is 3 times slower than the initial response. Isn't that right, Mark?
Yes.
You didn't hear what I said. I'll tell you.
3 times slower. Yes.
Okay, 3 times slower. So the first response is right now. So we can test that. Easier we can test the other. By the time it gets to where it is up and where the reticular formation is balanced and starting to plasticize, that's starting to establish our subluxation patterns. Permanency. How many times have you had a patient come in, you find an indicator, you adjust and the indicator goes away? Other times you adjust and the indicator is better. Still there. How many times, and you have to learn to be specific in your palpation. You palpate an indicator, palpate a trapezius. Is it edematous on top, and then as you get down through the edematous, is it fibrous? Is it all an edematous muscle contraction? That would be rather, that would be acute. But if you find that it's kind of soft on top, and as you get in, you find a hard core fiber, that tells you have an acute reaction to a chronic problem. So you can be picky, you can go right down and diagnostically, which beats the devil out of most of these chiropractors, and adjust everything from occiput to rectum. There's another word for that. So anyway, this is important because we've got two things going on at the same time. And again, I show this because there's a lot of ligaments of interest. We have a ligament going to S1. We have a ligament going to S3. Because these move. Between 1 and 2, or 1 and 3, is S2, which is the attachment of the dura. And we can't be jerking around on the attachment of the dura. We've got to work around that attachment of the dura. So you actually have ligaments supporting each one. We have ligaments down here supporting. So when you look at how many ligaments you've got and all the neurological input, can you determine a gluteal indicator, sacral 1, 2, sacral 3? Certainly. Because as you start firing here, you're going to have muscles start to support. So we got a ton of stuff going on all the time. This again comes out of the Dvorak and Dvorak. What these guys did, these are two Swiss neurologists, and what they did was they took a spine and they injected an irritant into a spinal joint. And then they went throughout the whole body trying to find what muscles reacted to that nerve stimulation. It was interesting because I wrote the paper and I included in the gluteal indicators years ago. Somebody came out and said, "Did you get that out of Dvorak and Dvorak?" I said, "What's Dvorak and Dvorak?" They came out with their book the same year in English that I had written my paper on the same thing. Matter of fact, I got mine from Denton. He only had L1-5 through here, and he didn't have an indicator. He said, "I noticed that there's sometimes muscle contraction." We didn't go beyond it. I found it. You have 7 movable lumbar vertebrae, right? Just like 7 movable cervical. But you got breaks on the upper 2 lumbar vertebrae called thoracics because they have short ribs. They're not full ribs. So that breaks the action down, so you have a better transition. People that have very short 12th and 11th ribs have a lot of stress in that area and has a lot of problems. So you have a transitional area to slow the stress down before it gets into the thoracic spine. But you have 7 movable factors down. Once you get up to T10, you have a rib cage that's fixed. And those vertebrae aren't going very far. So you can come out and if you inject in one area, this tells you where you pick the thing, where you'll find out what muscles attach. To have to go, and I mentioned in the paper, and I mentioned this, I said to have to go through all their particular muscles to be able to determine anything, you'd be a long time with a patient. But this is there. Matter of fact, those of you that don't have Dvorak and Dvorak, I suggest it's very interesting. From that, matter of fact, this is in there also. There's the gluteal indicators. Here's the lumbar. Here's L1, 2, 3. Now, here we go into the spine. And here, this is where they injected C4. Bingo. Right there. These are all the muscles that they found that reacted.
Did they do electromyographs?
I don't know what they did. I don't remember. It probably says in there. What they did apparently was consistent enough and good enough that they were able to put it in a book. Yes, sir.
I think it was largely palpatory,
Was that right?
and if you can find the original book, it's not it's not published any
Right.
longer.
Yeah.
The one that came out later has maybe a 4th or a 3rd or 5th
I got the first
of
2.
all of the
And there's-
slides.
Well, they came out with the diagnostic one. Then they came out with one on treatment. And they came out with another diagnostic and treatment. And now they got a 3rd combination. I haven't gotten that.
You can track down the original. It's got all of the spondylogenic reflex syndromes in it.
Yeah.
And it actually follows cyclical fibers and perfectly. Trapezius fibers, etc.
Yeah. Well, the main thing, because I look at it, a lot of them don't jive with what we do chiropractic with degenerate, with SOT. But it's there. Their trapezius is opposite ours. It's love-it relationship for what ours is, what we use. All right, so here is T5. And there's all the muscles that react with that. There's L3. Okay, so we go back now to how this thing works. anything that starts happening, any injury we have, any joint that's got an aberration, has to be able to try to reduce the stress on that particular articular function. And so varying muscles, you develop a syndrome of muscles that work with that particular joint.
How long ago?
And then as that joint adapts, and this may take a couple of days, may take 6 months. How many people you had come in and say, well, I hurt my back, but it got better in 6 weeks or 6 months as long as I don't do anything. It took that long for the whole body, not just at that particular joint to adapt, but now that joint has to adapt to all the way to the top of the head to the bottom of the feet. And the way it does it, establishes that first initial response, is through the propriospinal system, which is this system here. So everything that goes into the proprioceptive system also goes over here to go up through vertebra, down through vertebra, and up and down the spinal cord for that first reaction while everything is going to the computer. That's where we're. In the meantime, you're also getting an effect into the organ system, sympathetic. That's going to be involved in this. It's going to fire in to create changes, which we'll get into. Okay, so now we're talking about the reflex. And this is what's called the proprioceptive, short proprioceptive reflex. When you fire into the initial reflex, something has to happen. The first thing that happens when you challenge the body, the first thing that happens is the body, the postural system splints, stabilizes to protect your posture, otherwise you fall. So that's the first system. If we're talking earlier, you stub your toe, because maybe your knee lets go. You may even fall. Because it fires in, it contracts the spine to maintain balance. It's got to protect the central nervous system. At the same time, it doesn't want to hurt that joint anymore, so it goes over to the voluntary muscles and it says, relax. And it does. Otherwise, you'd be tearing. So then we go into the long reflex. Again, depending on threshold. You've got to fire beyond the simple reflex, the simple level. The guy's holding the door, and he trips and his knee goes. Still got control here. The next trip is a big trip. The threshold is reached and it fires up into the brachial plexus. And so it says, whoa, voluntary muscle. Let go. Sometimes you let go and you can catch it again. Sometimes it just lets go. I mean, it is not going to hurt. So you get splinting of the postural muscle and relaxation of the voluntary until you regain posture. As soon as you're ready to regain posture, you get back to the voluntary flow. How much it decreases the voluntary flow is dependent on how much of an impulse you have in there to cancel. Capiche? Not everything's black and white. So it's the same thing in doing the testing that we're going to show later. When you're testing an SI joint, are you testing enough to go all the way up to the arm to test the arm? Or are you just barely testing down here to where it's not going up and you don't have a test? You don't have to blast the third person to where the person comes off the table. But as with the patellar reflex, you sit there and you experiment to find out what that person's level of reactivity is. The same thing when you're doing an arm fossa test. I see people putting their hands on ilium, on bone. This is not a patellar reflex. Neither is it down here. I've got an area in there about half an inch of the tendon, patellar tendon, about 3/4 of an inch wide. And that's the patellar reflex. Man, that's a small little place to aim and hit for. And then you got to experiment. Matter of fact, you have to make sure you hit it. Matter of fact, anybody doing a patellar reflex, usually you do it a couple of times to be able to make sure you got it. So that's how specific it is. You've got to get to the right receptors. You've got to stimulate it sufficiently enough to create the reflex. Or you don't have a test. You can control mentally a lot of what you do. Stand up. See, this arm is strong. See, look here, hold tight. Hold tight. Jesus. But, get some more of that thing. Hold tight. And I'm weak. So depending on what, you tried just as hard, didn't you?
I did. I wasn't gonna let you show me out.
I fooled you. So, you can affect, and see, this is where I started teaching over 35 years ago. And I swore at the time I was not going to teach anything that anybody could screw up. Because then they're going to come back and sue me. Because I said, well, that's what he said. And I didn't want to make any mistakes, so that's why I developed the neurological testing. That's why I've done a lot of them. I want to make sure this is what you got, this is it, and ain't no two questions about it. Anything that I teach, I don't care everybody in here to test it. And it's there. So again, to be able to have this reflex that we're going to do, to be able to test propriospinally, you've got to understand it's the whole system that's involved, depending upon the location of where you stimulate. The amount of stimulation, you have to fire the reflex. You've got to get past the thresholds. The duration of the threshold, that's not going to do it. But if I put it there long enough, I'm going to hit more receptors. And receptors have a chance to be able to metabolize and get up. So I want you to understand that everything that we do in SOT training is neurologically sound. But you have to understand what you're doing and you can't screw it. If it works, do it the way it's supposed to work. Don't do it the way it doesn't work. And learn. And no two people are the same. One of the problems I've had over a number of years is I find the patients do not read the damn books before they come in to tell me what's wrong with them. I have to actually take the time to figure it out. And they try to confuse me, don't they? Find all kinds of different things. So the more neurologically that you can find and establish, the better off you can be. Okay, now, to kind of summate all that, we know that in SOT, we have the occipital fiber trapezius gluteal reflex chart. And this is pretty well bloody standard. I haven't found anybody that has been able to distort or say that that doesn't work. Unfortunately, I don't have any research, actual research, to establish. But everybody knows that, so I don't have to go over that. Now, we're going to go now into the importance. And as I mentioned earlier, we know the spinobasilar area. Well, what are the three most important areas we've got? Number one is the spinobasilar. That's the area for the main pumping area of pumping cerebrospinal fluid. Right above there is the hypothalamus, probably the most critical tissue in the body. That is our organ function. That is the thing that converts the fuel to feed the brain in the first place. So that's important. What's the next very important area? I'm going to see the ability to maintain this cranium. So we're going to have now C1, C2, C3. That's where the integrated system is. What do we have below that? Primarily, you've got the lumbosacral spine, because that deals with sacrum and spine to balance with the occiput. So now we have a whole other area. So the main areas are going to be lumbosacrum, suboccipital, spinobasilar. Very interesting. I have a friend of mine who's a good SOT, by the way, cranial, and he's really got big into blood work and doing nutrition. And he was complaining. He said, "You got to take more nutrition for it." He said, "I'm not missing something." He said, "I've got some cases I put them on nutrition, they get better. I got other cases that they don't ever get better." I said, "Because you're not fixing the bloody spinobasilar." He said, well, I do temporal, I fix this, yeah, but you're not focusing on why are you fixing the occiput, and why are you fixing the temporal, and why are you fixing the zygoma. You've got to get in and maintain and create the change. Once you release the stress, you've got to increase the mobility and function of the sphenobaselar upper cervical area. Just because that fixed your ankle doesn't mean that the damn low back is going to be better. I mean, you have to fix your ankle, then go up and work with the low back to be able to get it to balance to what it did in the foot. So if you fix the cranium, you better balance the cervical spine and the cranial motion, flexion, extension, and sphenobaselar. Ranges of cranial ranges of motion. Fire all those nerves in there. Get the circulation going for the hypothalamus. The reason that people aren't getting to use their nutrition is because the organs aren't working. They got all the chemistry they can use, but the hypothalamus is not stimulating the organ tissue to use the chemistry you're putting in there. So the parasympathetic system, that's what's going to control organ function, basically. The sympathetic nervous system going down the spinal cord is going to affect the blood circulation to it. Well, if the sympathetic system isn't firing, you're not going to get any sympathetic stimulus down the spinal cord. So how are you going to get out to the organ to open up the blood supply to feed the cells to reach demand? So you got to go back to the sphenobaselar. That is why we are in this work. Our whole objective is to free and clear and have the most efficient functional sphenobaselar pumping mechanism that we can possibly have. That's your whole reason. If you've got sympathetic, parasympathetic, if you've got cranial function, you've got cerebrospinal fluid, the central nervous system burns chemistry at a rate of 7 to 3 to the other cells of the body. It is the most susceptible to malnutrition. If you can keep that baby going, you're clean. The main area we're going to is that sphenobaselar area. Hypothalamus. That's all the function you've got. That's all the organ function. That's the metabolism. And of course, we know that. All that goes in there. As a matter of fact, we can break it down and we can show parasympathetic or sympathetic. Yeah, sympathetic system. So we know we have two different systems. You know, mostly the anterior part of that hypothalamus is more parasympathetic, and the back portion is more sympathetic, but it's integrated so that it works together constantly. And of course, you feed into it vision, you smell. If you hear a steak cooking, sizzling, does that turn your stomach on? If you smell a good thing, does that turn it on? How about if you see food that looks good? So that affects, everything affects the hypothalamus. But it can only work to the degree that the hypothalamus can work. And then you have the parasympathetic. We go back again. Oh. So we're now into organ function. We're now talking occipital fiber. Having an occipital fiber does not mean that you have an organ dysfunction. The occipital fiber, I feel, the occipital fiber occurs with impairment, dural impairment at a spinal segmental level. Matter of fact, if you will notice that the occipital fibers and the trap fibers pretty much correlate together. So when you have fixation or irritation or involvement that causes a neuromusculoskeletal problem that we pick up with the trapezius or gluteal, when it gets sufficient enough to where we are now impairing the cerebrospinal fluid, we're affecting the dura. Now it starts firing up on our other system, and it's going to that area of the occiput to be able to relieve the stress at that particular area. So that's where we get the occipital fiber to balance with the restricted area. And it's going directly to that occiput to get it to balance. Now, trying to find something on that is a little different. But anyway, that's my outline. So we've got that in regard to organ function. And of course, with the no chiropractic reflex technique, you've all got this, I'm sure. And with this, these are the various reflexes. There's more. We've got reflexes in the hand. We've got my God, you can find foot reflexes, you can find hand reflexes. You can find reflexes in a lot of things. Again, because anything that goes into the system, into the central nervous system, is going to affect the total body from the top of the head to the bottom of the feet. And it's going to find its pattern. That's why you can go down and get a podiatrist, you go down and you check the teeth. So you have a gallbladder, or a liver problem, or a stomach problem, because it's also balancing all the way down to there. Even medicine does. And this is out of a medical textbook. But these are things that they're showing for various organs. So there's a lot of things here that we all know about and we all use. But it's being able to understand it, it has to reach straight. By the time you start getting these guys, the threshold has been reached. You've got to start being able to diagnostically really look at shades of gray. Really be able, over time, you will gradually get to where it doesn't have to be a bang. It gets down to where, hey, this is just a little different. Matter of fact, I know people that can take their hand and go over somebody's body, and they can feel the differences in heat. They can feel differences in energy. So there's a lot. I'd say that, how many of you are students? 2 of you? Amazing what you got to learn, isn't it? Well, I say that, I feel sorry for so many students that are, well, I'm sorry for the ones over your school that are taking SOT USA courses. They don't teach anything. That goes beyond what was written in 1967. They do, nothing is new. But the main emphasis I have with students is not that I want to blow you away. I don't want to teach you, you didn't come here to learn something you already know. And I want to put something up there to realize where you got to go. And you have to, you know, life is a...
Box of chocolates.
Huh?
Box of chocolates. Life is a...
Oh, I'm getting there. Life is a triangle. And let me tell you, there's tons of usual and customary down here. Pop and break heartbreakers. And then gradually, as we learn, we begin to come up here. It's lonely up here. But if you don't have some place to shoot for, you can't get there. So I always liked it when I was down in Brazil. They complain because down there they don't teach much in college. And so I'm having to teach them. I'm having to teach chiropractic as well as teach them the central nervous system and everything else. And they say, oh, God, you're confusing. I said, good. Now they know where they got to go. And boy, they were all excited. We started out with 75 people, and there's 75 people all the way through to the last one. And I don't want them to quit. Because I'm the only one that talks to them about patient care and involvement, how this works. You can read it in the textbook, but then you don't learn to apply. And that's why I say with this, for the spinal thing, I want to get it to where you understand it, where you can deal with it Monday morning. But the thing is, you have to understand, in any profession, any job, it's all where you want to go. How good do you want to be? These are the guys down here that are having to advertise, having to get for patient management seminars. I've never had to advertise because people talk about it. Boy, you ought to go with this guy. And let me tell you something. A lot of patients don't like it because I pretty well tell them like it is. I'm very honest. I turn them off. I have people that leave. They come back. Well, he doesn't do what you do. Number one, he doesn't even put them in a gown, doesn't put the women in a gown, doesn't have the men take the shirts off. Adjust them in an overcoat, doesn't matter. All he wants is crunch. But I'm a professional, I'm a doctor. When they come in, they're gowned, they got the shirt off, and we're professional. And I take the time to ask questions, we can go in later. But if you want to get ahead, you want to practice, then be a professional, be a doctor. It's interesting because I do an exam on a patient and they say, geez, nobody ever did this before, including the medical doctors. Nobody does it anymore. Take the time. Be involved. Take the time because you need the information so you can do a good job so that patient doesn't quit or it goes out and tells more people. That's why you're there. Now, not closer. Okay. Okay. Oh, here we are. Well, patient analysis. This is important. This is our proprioception. This is what you need to know. As we've already discussed, patients do things in patterns. When something happens, something happens. Everything is involved. And so you've got to take the time to find out what it is. And the most important thing is to ask the patient. I can't begin to tell you how many patients, because I take them back all the way to day one. I ask if they know if they had even had any trouble birthing, if they had any trouble when they were kids. And I write on through the line, have you ever had a little back? The women, I ask, when you first started your menstrual cycle, did you have cramping? Well, yeah, pretty bad. Well, then you hurt your back before then. Because that's the nerves that go to the uterus. Or whatever. Did you have sinus problems? Did you have lung? Yeah. Take the time to get back there. Because what you're doing is you're going through, well, organ. If I go through it, I've had a history of any heart problem, lung problem, gallbladder, breast, T4. Any problem with stomach, T5. So as I go through the organs, what am I doing? I'm checking for subluxations, spinal involvement. And I also want to find out the degree of. If, well, yeah, I used to have problems in here. Oh, gallbladder. Okay, that's a little bit of gallbladder, a little bit of T4. But they finally got so bad they did surgery and it was really bad. Oh, you know, bad T4. How's your digestion? Poor. T4, T5. So see how one thing starts playing into your system. And that's proprioception. When you put a stretch into the gallbladder, the bile duct, or anything like that, it's going to reflex back spinally. It's going to create the pattern. So you can have sympathetic involvement coming back, creating it. You can have neuromuscular. You can have respiratory. So you got 3 different things going on all the time with these patients. So, consultation. Do an exam. An appropriate exam. I'm going to show you the one I do. Mainly, it's a proprioceptive analysis. Would you say range of motion is proprioception also? Of course it is. And then we get to the integration, subluxation syndrome. Now, this is the main emphasis that I want to make, and I've made throughout. No one thing happens in the body that doesn't have to occur throughout the body. You create a syndrome. And the body and God are a hell of a lot smarter than most of the medical profession or any of the chiropractors. It knows, and it's consistent, and it knows what it needs to do. And it doesn't. But finding 1 or 2 things out of a 20-thing syndrome may not be definitive enough. The more things that you can find that are associated with this thing, the more you become close in your diagnosis. You know, you've got to add it too. If I've got a problem with a stomach, gallbladder, I also got a problem with constipation, also got a problem with swallowing. You know, all right, now I'm starting to build a syndrome, and I know where I got to go. And that's what we want to, the integration of what you've got. Okay. Consultation. I don't have a whole lot of things on there. I have patients fill out something. They never fill out what the hell is important anyway. So I just ignore that. You know, they put out what hurts most. Well, I'm not interested in what hurts most. I want to know what's going on. Because the thing that hurts most is because the other things have already broken down and are not there. I'm having all this because I've had the uterus taken out, I've had a breast removed, I've had a gallbladder taken out, I've taken insulin for my pancreas, but I got a little back pain. That's the only thing I want you to take care of. So, there we go. So anyway, I do a consultation, chief complaint, history, this is where I go back and I suck. and I work my way down. Ranges of motion, compression, distraction. I go to lumbar range of motion. I look at the back first because that's what the patient's in there complaining about, my back, for the most part. So I start there. Also include cranial. Lumbar, cervical, lumbar range of motion, turn around, face me. Patient faces me, I check check for any cranial nerves. Then I can do motor testing. You can do motor, reflex, and sensory. Motor is the big nerves. Sensory nerves are smaller. So when you check, if you have a DTR, you will pretty well assume that you don't have or muscle weakness. If you've got muscle weakness, arm testing wise, that's the big nerve. Motor. If you have a DTR, this thing, now you're getting the receptor. Now you're getting smaller. If you've got sensory, you've got smaller. Most nerves that are affected are the large nerves. Those when you get any disc or any joint occlusion of a nerve root, distal type thing, primarily the big nerves are the ones that are the first and has motor weakness. So anyway, cranial, brachiomotor, DTRs, pinwheel. So I'll come down everything on the front. Then I turn the patient over. And I start at the top. Motor testing, I'm at the bottom. Motor testing. Then I can do straight leg raising. And then I do what I'm going to show you, the neurological testing for the SI. And as I was mentioning to you earlier, if you'll notice here, I've got orthopedic, neurological, respiratory. A sacroiliac joint, it's got 2 ranges of motion. It's got a support weight bearing, so it has an orthopedic problem. At the same time, it has to have a system that is monitoring cranial sacral respiratory motion. So now I have to check the respiratory. Is the respiratory involved? Is it from the cranium or is it from an osseous subluxation? Orthopedic, that's what the orthopods use, that's what the medical profession uses. That's the only one they have. You stress the joint, if it doesn't hurt, it's okay. What if the patient's threshold is high? What if it's an old healed lesion? You're not going to, whether it's fused together, locked, no motion at all. You couldn't hurt it, couldn't irritate it with your heart device. We got a clown in art down, a neurologist or a neurosurgeon. He's driving pegs in there and he's fusing the damn sacroiliac joint. Takes all the pain out of the joint. Of course, the other one's working like hell. But anyway, so again, I start with a system. Just stand up. So I'm here and I do range of motion, check rib head, check scalenus for category 2. I can palpate cervical spine. Oh, you're going to left this high? Actually, I'm going to right this high. And we come down and check bilateral musculature. Down here to the pelvis, to range of motion here, turn around. I can have do all the kind of things I want to do here. Then I come up here, hold tight, and muscle test, motor, DTRs, whatever I want to do there. Then I get them on a table. And I'll have to put the table up there. Now I come down to the feet. Motor test, straight leg raising. I'm working my way up the body. I'm going through this because a lot of the problems most chiropractors have is they do not take the damn time to do an examination, find out what's going on. Number one, they don't know what they're looking for, which is why we're going over the proprioceptive system. Number two, they don't want to take the time because the patient can't for the adjustment. 80% of the office visit is adjusting, 10 to 20% is diagnostic. To me, 60-70% of it is diagnostic, 10, 20, 30% is treatment. If I find out what the hell I got to treat, it takes a minute to do it. I don't have to adjust this whole damn body. And go where I have to go, get the thing done, get the hell out of there and pay the bill. Start over. So I'm trying to accumulate as much information as I can. So we're doing motors. We have straight leg raising. We go up. For bear, for deer. We're doing neurologically. Check hamstrings. Check lateral thigh, medial knee, fossas, arm fossa. Go up, check the gut. Come up, check the shoulder. Come up here, do stair step, check Oxford C1, C1, C2, check cranial ranges of motion. Leave out anything? I think I pretty well hit about everything there was. I can do this in about 15 minutes. Less. Depends how fast my secretary can write this stuff down. So it doesn't take long, and you've got a ton of information. And that's what you're looking for. So, and then of course got the fibers stuff down there. Also vertebral segmental fixation. And because there's a lot of, and see, segmental fixation, we're talking insurance. And it's got fixation in the lumbar spine, see. So a lot of little things I have in here, this is for the insurance company. And this is to prove that I did this. I'm a doctor. And I would die. Matter of fact, they say, well, you're supposed to put something in everything. Baloney. What I do is I come down and I just check here, which means I did it. Here, I may put liver, stomach, DTR, check. If I don't put it there, I just check that I did it. But just everything's on there that you could ever hope to have. I keep adding to it. I'm running out of room. Now, once you get the consultation, once you do the exam, you send them out for getting some x-rays, and then you put the thing together. Now, I'm suggesting this I started doing for the insurance company. Because at that time you had to send something in every now and then to show that you were monitoring re-exams, things were changing, things were better, whatever. Treatment schedules. And then I realized that what it was doing was making me sit down and put together consultation and the examination. Make me do it because otherwise I'm busy. And I don't do it till the patient walks back in and say, oh, and now I got to sit there and try to look at the damn films, go back and, now I'm trying to put it together. Whereas if I sit down and do this to begin with, and I can include the x-ray summary on here. So I got the whole thing in my head. When that patient walks in, I'm ready. I don't waste any time. This is my day sheet. Again, I do a mini exam. Matter of fact, you can even see for Bear, orthopedic, neurological. Here's respiratory. Respiratory. So I can actually check orthopedic, neurological, or respiratory dysfunction. Right, left, upper fossa, or upper weight bearing, or lower weight bearing. S1 or S3. So I can be very, very, very specific. And I try to leave gaps in here where I can write anything I want to write. Because I always got something else I got to ask. I may want to put in there navicular, foot, something. So anyway, this way I can go back. The patient goes in and says, geez, whatever you did the last time really worked. Damn, did I write it down? Back and take a look at it. Why don't you do this? Well, you go back. But at least you go something, you can go back. Then a lot of this is for the insurance company. Well, not just insurance. Self-care training, I always charge extra. I never charge straight fee. If it's insurance, in particular, so somewhere right here, passive care. Yeah, I can do that. Therapeutic. I can add in there anything I want to add in there to document it. What I will do is I will sometimes put in active care, self-care teaching. I don't do any PT anymore, speaking of. But I do I explain to the patient and demonstrate an exercise I want him to do. It takes time. And so I'll put them in. If I didn't spend a full 30 minutes, I can put them 15 after the number to make it shortened. You guys in the office know what we're talking about, right? But I always charge it. I never charge for an office. I don't know how to. My pen doesn't knock my head out, But I've got everything I can think of on there If I want to go back, I can go back, because you're going to start looking at syndromes more and more and more. This gives you the opportunity to record syndrome. You can record organ dysfunction. You can record things getting better, not getting better. You've got to have a paper trail. Yes, ma'am.
So you're adjusting on the second day?
Yeah, I don't do anything. I may do something to release some pain or something. But, you know, if I have somebody with acute pain, to come in, I'll do something just to get them in pain. We're not going to adjust it per se. Depends on what it is. For the most part, I explain to them, okay, we did this, I want to get a picture, I want to see what we got to do deal with. And they understand. No question. Okay, fine. We can be back here tomorrow. Be back this afternoon, whatever. We got to get that. Put it together. I x-ray every single pelvis. Period. I was amazed at what I missed over the years. Because I didn't save them a lot. I didn't save many. It cost more trips than me figuring the damn thing out, why I'm eventually getting an x-ray anyway. Not a lot. So I just do that. Period. And so we want to see if there's any extended damage. I don't want to get in and upset something that's got, you know, a lot of wear and tear, degeneration. We want to work with this. And they understand it's not even anything. And so when I come back and I get x-rays, now, if I wasn't 74, I was a lot younger, I'd probably get one of the big screens, put it in the office, so I could put my laptop on there and put the video up. But I can't on a laptop show a patient an x-ray well than I can on a film. So I like my films. I got a radiologist that puts them on film, so I like it. He ain't gonna argue with me. So he sends all mine down on film. And I can put them up there, and a picture is worth 1,000 words to the patient. They now see it. Now that you can see it. Otherwise, you're trying to look at this little damn screen on the damn laptop and trying to figure out if this is this or that's that. Phooey. Now, maybe if I got a bigger screen and I pump the laptop into it, maybe I could enlarge it. I haven't looked into it because I'm not going to invest the money. But not at this stage of the game. So anyway, that x-ray is worth 1,000 words. Now people got a visual. Now when you ask this, it's going to take some time. This happened 20 years ago. And you see the amount of degenerative change in here. You see how this is distortion, and you see on and on. And now the patient understands what you're talking about. So like I said before, I'm not here to teach you neurology. I'm here to teach you how to be a better doctor. And that's why you're here. Yes.
5 minutes till break time.
Good. Just about that. And that was it anyway. Okay, let's go take a break. I'm going to put my table up and we'll come back. And I want to go through some of these indicators. I want to show you something. I want to show you the Oxford C1, C2. I want to show you the neurological testing for the SOT. So that you can get a handle on this, because those are your major things. Okay, everybody out of the pool.
I have the stamp. Also, I encourage you to visit our vendors. There's Mr. Bill Hampton is offering, when you buy a lotto ticket, a $4,000.
Right. Okay, everybody here? Okay, what we're going to do now is we're going to go into, primarily what I'm going to go into is I'm going to go into the SI joint, neurological testing. This has been probably the most important thing that I've had occur in my practice. If there's two things that I have developed that have been outstanding, one was the cranial range of motion. I can very specifically, with the cranial range of motion, determine what's going on with the SI or the low back. Very specific. Now being able to go back down and neurologically test the sacral actually, I'm amazed as to what I'm doing. As a matter of fact, I go down and I treat the SI joints and the pelvis and everything else, then go back up and check the cranial ranges of motion, see what's left. Then I have to go back down. Matter of fact, we had to do this the other day. Went back, we had something, we did simple mastoid suture, or a simple parallel suture just wasn't tracking. We had the one fixed, and we had to hunt around until we found which vertebra was in the syndrome. And we had to check. We had to check it with the surgeon, perhaps in lumbar, or whether it was in the extremities. So what I have done is I have gotten the ability to give you much more specifically, diagnostics. Now, another thing that I found, and I've had to do, is it's amazing how many of us get an x-ray of the low back, and our eyes never go below L5S1, because that's the only thing you can crunch. And let me talk about crunching. All chiropractors have to hear a pop. Now, I don't know, to some chiropractors, the pop is a rupture of a capsule, too hard an adjustment, or whether it's breaking the amount of compression. You have to understand that an adjustment is taking a joint to the end of its range of motion, going beyond the range of motion sufficient enough to fire nerve receptors and break fixation. If you go, the more you go beyond the normal range of motion, you are now creating strain, sprain of a joint. You are now creating scar tissue. You're now stretching ligaments. You're now creating more permanent damage. It's not just a little stimulation. I don't think the activator, I think the activator is a pile of crap. I don't think that you can get enough stimulation to go beyond the primary aspect of the propriospinal system to be able to go up with enough threshold and enough innervation to be able to reach into the spinobasilar area, that's the particular formation, to be able to create a significant change in a pattern. I think that the activator is great for a simple reflex situation. I think that you have to take a joint, and I'll even show adjusting, and some of you know how I do, and you have to understand, I'm a partial paraplegic. I'm only weigh 130 pounds, and I can adjust that. And I can get pretty good results. I do not depend on a pop. I depend on what I feel. And I see a lot of people that take a vertebra to the end of its range of motion, and all they got to do is just go a little bit to create that stimulus, and instead, they take it all the way to the end of the range of motion, they back off, and then they hit it with both feet. And they don't feel anything and take it beyond the range of motion and tear the joint. Great example. So being able to adjust is a very specific neurological orthopedic event. Not orthopedic neurological, it's neurological orthopedic. When that joint went beyond its range of motion, it contracted and locked it right there. So you've got to break that up, and you've got to take it back, and you've got to stimulate those receptor fibers to break that pattern. And then you've got to go through the pattern, subluxation pattern, to be able to determine other things that have adapted to it. And a lot of it isn't a crunch. It isn't a pop. When that joint is first compressed, you can hear a little pop. You can hear the compression. But after that, it doesn't compress enough. You're not going to get that action. You're not going to get that noise. Because it's not that bad. And I hope that you should have less and less noise on your adjustments as the patient goes, but you're still going to have to stimulate receptors. Well, that didn't move, Doc. Oh, yes, it did. You just got to reinforce it. You got to tell them. So, an adjustment is a neurological experience. It is not how hard you beat the damn thing to death. But it has to be sufficient enough to be able to go into the whole proprioceptive system. You've got to be able to go through the whole thing. You've got to take it to the end of its range of motion and be able to create enough stimulus, and you can feel it as you do it. Okay, now, as I said, we get x-rays of patients low back. We never look below L5. I've had a very tough time with my radiologist. Matter of fact, I just talked to him again the other day. The x-ray tech, I put down, I scratch out the word lumbar, and I put lumbosacral. And And invariably, he cuts off the bottom of the damn sacrum. I can't tell you how many, and I'm going to show you some here, where you'll see, and you know that the sacrum should have a normal arch. Well, you're going to be surprised how many of them look like this, where it just flattened it out and broke it. And it's usually about L4 or 5. I'll see S4 or 5. It's because the S3 stabilized it enough so it broke below that. And then you're going to find superior. So you get a lot of orthopedic lesions in there, but you don't see them. And you got to remember to look at it because you're going to see some things in here that you won't believe, or you've never looked at. I didn't believe. Okay, so first I just went up a normal SI. Okay, this is probably the most common thing that you'll find, and this is a superior ilium. Because people will fall on their butt and they'll land on an issue and they will drive it superior. And where you look is right here. Can you see the difference here? See, this should be a smooth line. Can you see how this goes? Up. And that's a superior ilium. And you can adjust that to a cow's foot any other way you want, but unless you take that sacrum to the superior and put it back in place, you're going to have a right SI syndrome, right sacral, right temporal, right shoulder arm. You're going to have everything going on. So that is an important thing. Now, I did a paper on this 100 years ago. And because I didn't have the neurological test then, I used, as a matter of fact, I did this on DJNet. I showed him. And he came in. You know, DJNet would not allow anybody to teach anything except people, this material. If he caught you teaching anything else, you were out of the seminar. Well, I had been working around in this. I had a truck driver. And he was coming out of his truck, it was raining, and he put his foot on the running board to step out, and he went to go down, and his foot slipped, and he landed stiffly on his right side. And he came in, he had a stinking neck and a low back. I was working on his neck, worked on his lumbars, blocked his category 2. This thing persisted. I finally said, wait, let's go back to the accident. What did you do? He said, I landed straight legged on that thing, and I just, oh man, I just jutted the crap out of me. I said, well, you know, the only thing you could do would be to drive something up. So I checked around. Sure enough, he had a hamstring on that side. all the sacroiliac indicators. And what the hell? So I just turned him on the side, and I adjusted the sacrum superior to the ilium. Speak louder again. Okay. So I adjusted that sacrum, I went back and the hamstring was gone. I said, whoa. And so I started checking some other things. And so I started using palpatory findings, like you would use the UMS and the LLL. And you would use the first rib head. Well, I used the first rib head, but UMS and LLL may not have a torsion name. So I had to find some other things. So what I found, with an ilium move superior to the sacrum, unilateral persistent rib head, same side tension and or pain of medial hamstring tendon. Now, the medial hamstring tendon is innervated by L5. So you have to adjust the L5 to release that innervation to the muscle that you're testing. Because that muscle is spasm. Is it because the muscle is irritated, or is it because it's trying to compensate? See two different things going on? One is a proprioceptive finding, compensation. The other is a nerve root irritation. Catch the difference between the two? So you adjust L5, it didn't change. Still got the hamstring. Well, then it isn't a nerve root. Maybe you adjust the L5, you go down and check the hamstring, it's half that. Part of it was. But the other part says SI, or something else. So that's where you check. If you have a medial hamstring on the same side as rib head, and you will also find, and I don't have it here, gluteal indicators. The gluteal indicators on that same side will be all contracted. If you've noticed going to a pelvis, you go to check the gluteal sacral indicators, you find all the medial gluteal indicators, sacral indicators, all tight. That's either from a superior inferior or it's from a lateral lesion. If it's superior and inferior, if you got the hamstring, gluteal indicators, and the rib head, all one side is a superior inferior. Adjustment, put the indicator side down and adjust it. I'll show you that. So now we have an inferior. I had a guy, he was walking around the back of a shipping dock. And there was a bunch of crates and boxes waiting for the truck to come in. And so he was walking around trying to get by, and he stepped off, and when he came down, he landed on the sacrum and on this issue. And this leg just dropped. Look what happened to the leg. So he had an inferior leg, because when he fell, it stopped the sacrum and the other issue, and this leg weight just drove that down. So he had an inferior. So unilateral rib head pressure, tension, quadratus, and borum. Oh, if the ilium has been driven superior, number one, you're putting a stretch into the hamstring, which is going to cause a reactivity. Number two, if it is going far enough superior, the muscle is going to contract to try to pull it out of lesion. Pull it inferior. So if you have an inferior ilium, you're going to be pulling stretch onto tendons, go by tendon apparatus, etc., which is going to cause the muscle to contract. And also you have muscles contract trying to take it out of lesion. And that would be the quadratus lumborum. The quadratus lumborum attaches to the 12th rib and to the medial, what have I got, 5 centimeters, right medial of the L5. So if you've got it up, now, if you just have the upper quadratus lumborum, that could be a T12 or a rib subluxation. If you just have it to the right of L5, that could be an L5 or L4. But if you have upper and lower showing contracture of the whole quadratus, then you know that it's trying to pull the ilium back up or getting stretched sufficiently before it's reacting. Proprioception. Anterior posterior. Many times I noticed, I started looking at SIs, when you put them up there, you look at one ilium and you can see it's like this, and the other ilium's like this. One's flared and the other isn't. And yet the sacrum is bilateral. Well, then I started going back and thinking with some patients. I've had some patients who have landed hard on a butt, and they have hit so hard in this direction that they have just driven the whole ilium, the whole sacrum under the ilium. Now, you have a lateral stress. Proprioceptively, what is it going to do? It's going to have to compensate for a lateral stress. So where will your indicators be? They'd be over here for this posterior ilium or anterior sacrum. They're trying to get over here, trying to pull this away. The rib head would be over here. I've had people who have been hit this way and have pulled the whole sacrum posterior on ilium. The rib head's over there, the muscle contraction gluteal indicator wide is over here. So again, you have to look at the muscle contractures, and the things you've got is what is the propiospinal, what is the proprioceptive reason for this contraction? Why? Is it within a nerve pattern, or is it as a direct compensation to relieve a lesion? If you jam a joint, all the muscles around that joint are going to contract to stabilize that joint that was sprained. And then you're going to have the counterbalance for that. So essentially you can look at the muscles that you find palpation-wise, and you have to determine, is this a muscle, or does that involve with inflammation, irritation? Is it just strictly a muscle contraction? And no, you have to really go to show the respective irritation or pain. So we have two different things going on. We have reactivity to an injury, and we have the compensational proprioceptive result. Yes, sir.
How do you find like short, anatomical short legs playing to
There
be,
is no such thing as an anatomical short leg unless they've had a fracture of the growth center. Period. God did not. Did you ever see anybody with a short arm?
Yeah.
You measured it from here to here with a short arm?
Yeah. I do.
Without trauma.
Well, then I sure want to see their growth center, see what
Maybe
fracture.
maybe we'll talk about two other things. Stand someone up, and,
Yeah.
and you see the femur heads that are significantly in different heights. Assume no trauma. Assume trauma. However you want to. The femur heads from a standing X-ray are significantly different.
I say you would have to look at the torsion in the pose. I do not believe, and I laughed at Carrick, I took the neurology course. He was telling me a measure from the ASS down to the ankle. Well, what if I change the ASS? What's that going to do? Oh, that's not what medicine says. That's what it is. Who knows? Medicine doesn't know anything.
Well, I don't buy into the measurement thing either, but
Yeah,
standing X-ray.
well, then I would look at the ankle. I'll bet you find a flat foot. God did not make one side different than the other. And if you have somebody with an actual short arm that you can measure, then they've broken the damn thing. There may be some somewhere, but I have never ever run across one that I can never remember, and I don't remember everybody telling me that. Yes.
I have a significant 1-inch short left leg, but the reason it's short is because the femoral angle on one side is drastically different than the other.
That could be.
Not really a short leg, it's more a femoral angle problem.
And that would be something you may want to look at on the x-ray. See if there's a change. Something changed somewhere. And a lot of these things happened back at the time. It used to be when somebody fractured a leg, they used to meticulously try to knit it right back together exactly. You put pins in there. Now they just bring it back in the general direction because they know if they can get it to heal there, over time you have remodeling bone and it just makes it strong anyway. So bone grows according to the stresses on it. I've got some craniums at home. And when you look inside the cranium, to see at the occiput, you see where the dura, or the falx cerebri, is doing this. Where one tentorium is here and the other tentorium's up there. Because of the torsion and distortion of the cranium.
Good pictures of that?
No, I got the actual skulls.
I'll take pictures for us.
Yeah, right, that'd be cool. But you see these. Matter of fact, let me tell you, I was in Texas College one time. I had an intern from there, and when she graduated, went out for graduation, and they were selling all their old skull models and spine models. And they were selling, all the ones they were selling were the abnormals. And I had a real nice, matter of fact, I had them out a couple of years ago, I sold some. Sold one, I had one where it had a sacralization of L5. I had one that had L4, 5S1 with joints that went all different kinds of ways, and at L5 the joint never went all the way through the damn lamina, so it didn't move anyway. Absolute aberration. I've never seen anything like it. I sold that. Got a bunch of skulls. I got one skull. There's no condyle, and it's got full set teeth. Amazing. But it's amazing what the body will do to take care of itself. It's amazing. I just wrote a series of newsletters, and I was talking about cranial disease. I was talking about the young kids with malnutrition, etc., and how the lack of growth in the maxillary area. And the fact that, it takes time to release that stress for the bone to remodel. And the dentists talk about remodeling. What is orthodontics? Remodeling of teeth. You put pressure on a tooth, and that change in pressure in the socket changes the calcium and the tooth moves. So you change the stress into any bone, and you're going to change the trabeculi and the weight-bearing structure of the bone. So again, and I'm just giving you one area. You have to look at all the aberrations. This you're going to find every patient walks in the office. You're not going to find congenital short legs every time. So I'm trying to hit the general thing. Okay, anterior posterior. So, linear indicators. Sacral indicators 1 to 3 on the opposite side of persistent rib head tension or pain. I said it's either one way or the other way. And I'm going to show you how you can determine it. Oblique sacrum. How many of those have you seen? How many where they've landed and drove that have sacrum inferior oblique? Is this posterior to this? Is this anterior to this? Is this anterior here, or is this posterior to this? Something had to happen joint-wise to be able to get an oblique sacrum, period. That ain't the way he was born. I hope, but better. Common indicators, combinations of the above. Check the rib head. You're going to check the rib head, that side, you adjust it, that rib head goes down, you check it now the other rib head. So you go over to check that, you adjust that, and you check, oh, that rib head's better. Now you're back to the other one. So then you gotta go back and see what you missed over here. And you may have to go back and forth a couple of times before you clear both rib heads or cervical spine.
Do you find it helps to get people weight bearing between adjustments when you check rib heads, like just to look
Yeah.
at proprioception?
I'll tell you, when I have somebody lay down at the table, all I do is reach up and hold it, check the cervical spine, all fingers. If one side of the cervical spine is more contracted than the other, guess what? Sacral head. If I check both sides, I got contracture down low, I have an upper thoracic or rib head, or it's a clavicle. If the contracture is up the cervical, upper top, I got an L5, L4. If it's in the middle, I check to see if there's a specific. As a matter of fact, I check to see whether or not I've got which side is the most contracted. Total. That's the SI because the whole side is going to be contracted. Even. On top of that, I may also have an increase here beyond that. I may have an increase here beyond that. Have you ever had an SI and on the same side you got a clavicle or a first rib? You had to adjust? Do you ever have to adjust the cervical also? So could you have had a, but see now we're taking a neck and we are specifically diagnosing and taking apart how many things do we have going on in this neck? Sacroiliac, we've got a clavicle, and we've got a C1, 2, and a low back. We've got 3 things going on. That's why the guy walks in like this, being one thing. Right? Okay. Indication, combinations of everything. And let me tell you, you ain't seen nothing yet. Sacral segment. I can't begin to tell you, this is probably the biggest thing that I've ever run across. Anytime you have a persistent tract 3, stomach, you're going to have a sacral walk. Remember how I told you that that is probably one of the most important body weights in the body, joints in the body? Everything in the body sits right on these 2 joints, and that's one. Everything. And it's got to do 2 things at the same time. It's got to support your weight, play football, ride a horse, go tumbling, and at the same time move with your respiration. If you screw up that S1 joint, I guarantee you're going to have problems. When you do the cranial ranges of motion, and you go to the occiput, and you do torsion, if you get a locking of the right occipital-mastoid suture, not resistant, locked, you got an S1. Because that skull has reached its maximum allowable torsion. You're going to have to unlock it all the way down here. And that has been one of the biggest finds. Interesting, I had a turned out after I partially paralyzed, and surgery for both 2 artificial discs in my neck, and also some surgery for an L5 disc that they thought was. It turns out that now that I developed this neurological testing, I had bilateral anterior S1s. Do you know where the main disc was that was involved? S1, L1. Love relation, I mean, it's this relationship of the trap relationship, trap luteal relationship, S1, L1, T4-5, have had a gut problem digestion-wise for years. What's the Lovett relationship of L1? C5. Do you know what the biggest disc problem I had was? C5. That and mother herniated right out into the nerve root, and I can't use that, I have a hard time using that hand. How about that for a syndrome? And you don't know what I've gone through fixing my head. Holy crap. That's been fun. But anyway, sacrosegmental. And you're going to find it S1, S2. And I'm going to tell you, look at the lateral picture of the sacrum. Always look at the S1, S2 sacral segment. Notice if you see sclerosing at that S1, S2 sacral segment. That tells you the degree of stress that's going on, constant torsion. That will tell you where you're at. You can also find it at below S2, where they hit way low and they move the L3, or S3 rather. Well, you find all kinds of combinations. I remember I have a kid in the office now, he's 9, 10, and he has got a failure. He had a segmental subluxation that comes across here and up and across here. You can see the line where it just never moved. It's like he was trying to build a lumbarization, and the lumbarization went to L2 on this side, or S2 on this side, and S1 on this side. I couldn't believe it. And I'll tell you, the more you start looking at these things, and you start seeing the deviations and changes, you will be absolutely amazed. And you should see the change when you start fixing some of these S1s. You've got to really work on those carefully. Particular effort. Sacrosegmental. Use gluteal sacral indicator to persistent rib head involvement. Again, use the S1, S2, S3. And remember, it's a lateral lesion, so you're going to find the contracture of the sacral indicator opposite the site of fixation or irritation. And you may have both. You may have a combination. You may have that's anterior, this down here is posterior. You may have this anterior and the S3 posterior. In other words, the whole ilium is got posterior and anterior. A true PI, total PI. Geez, I wish you quit flashing the damn lights on. People watching these damn videos would wonder what the hell's going on.
They're trying to keep you.
We want to be able to see you. If it's dark, we
I
can't
know.
see you.
All right.
And to bathe our eyes upon your countenance, sir.
Oh, yeah. So, this you're going to find, you're going to get varied indicators. And this is what I showed DeJardette. I started telling you, I had come up with this, and DeJardette was down here in Orlando teaching. And every time he'd come down here, he'd ask me to adjust it. And so I would adjust it. And so this year, I've been playing with this. I said, let me show you something. And I showed him the indicators, which he understood, such as the UMS and LLL. And I explained, just like those, look at here. And I checked the hamstring, the quadratus, and so forth and so on. And, good. I said, well, now I got to adjust your sacral disc. He said, of course. All right. I got in adjusted. Yeah, that's good. So that year, I was in charge of Omaha. Homecoming conference. So I put me a class first thing in the morning on my superior inferior abdomen. I figured I'd do that because maybe Dr. DeJardette didn't get up real early. And I thought, well, I'll just do it then. He won't know because he might throw me out. So I went down there to teach class and sitting in the front row is Dr. DeJardette. Oh, crap, I'm in trouble. So I started teaching, and the class filled up. And I said, okay. I finished. I said, now let me have somebody, somebody have a persistent sacral that they will use a demonstration. DeJardette got right up. Came right up on the table. So my demonstration We teach her that himself. What had happened is he had a bad low back, and he was sitting on the edge of his bed, and he was trying to put his socks on. He couldn't get his leg up, so he threw his leg up, and when he did, he pulled his butt off the bed. And he landed right on his issue. He knew he had a superior alien, so he came right down to my class, so I could fix it. So that's my story on it. See, that's where Bloom and the others, oh, you can't do this. Teacher had approved. He was, I adjusted him. I know he did. But anyway, once you start using these gluteal indicators, you start checking. And then gluteal, and then go out and check the, not just the sacral indicators, but correlate with the gluteal indicators, and correlate with the trapezius. You may have a lot of gluteal indicators, you may not. Matter of fact, let me tell you. S1, 2, 3, gluteal indicators. Where does that go lumbar-wise? Gluteal 1 is L1. Gluteal 2 is glute 2, but S2. S3 is glute 3. And that goes up the lumbar spine. What I've done, and you saw that on that exam sheet, I go through and I test, put on there vertebral fixation. Every one of them, L1, 2, 3. The sacroiliac fires into the propriospinal system, creates the patterning, fires into the lumbar spine, locks the L1, 2, 3. Now you got L1, 2, 3 is locked. Now you've got supposedly 5 or 7 vertebrae in that low back that move. You've just eliminated 3 of them. Now if you've got a low back problem, and all your motion is now coming at L5, S1, or L4, L5, is having to make up for 3 vertebrae that you've lost movement in. How much do you suppose you're going to beat that thing up and degenerate that disc? The only way you're going to be able to get the pressure off that L4, L5 is to fix the sacroiliac. Then you have to go up to L1, L2, L3, because up here it says it's locked. When you adjust that sacroiliac joint, you've got to go to the lumbar spine and make sure that you reestablish and put stretches into those receptors. Break that thing free and get it moving. It ain't a matter of pops. It's a matter of motion and continually firing nerve receptors, Golgi-tendon apparatus, spindle cell receptors, constantly firing so they're feeding into the brain to change its position. Then you got to go up to T4-5. Then go to the loving relationship. Every single S1 I've had, anterior S1, I can go up to C5, and that's there. Every single one. And it goes right to this oxygen, right to the mastoid suture. Every single one. Okay, okay. So what I've done was I've established a neurological system to be able to determine or to be able to differentiate how much of the joint lesion is osseous and how much of it is respiratory. We can do an arm fossa test to determine as to whether we got torsioning, because when you torsion, when you move that ilium posterior, it puts a pull on the ilium. What is this? Not the
Sartorius.
huh? Sartorius. So puts a pull into the sartorius, and you can test where the receptors are in that upper sartorius. When the ilium goes the other way, it puts a stretch onto the rectus abdominis. And when it does, it creates tenderness or pain, and it reacts. And you can palpate. On the tight side, it's the positive side, that this is done this way. You can palpate over here. And you can determine. So we have actual things. We can chop out here and here. But it's proprioception and balance. So what I've done is you can generally take the joint like I showed here. I should have done this differently. But you can take the whole ilium posterior from here. It's a neurological test that you've read in the textbooks. Flexion, abduction, external rotation. And what they're doing is medically they're testing hip joint. But if you take that down and you stress into the ilium, if you move the joint more into subluxation is going to be reactive. If it creates pain, if it is restrictive and or creates pain, positive orthopedic test. If it's just restrictive, doesn't create pain, medically they say it's okay, but it's not. And sometimes the amount that is restricted is very high. So there's got to be a way that we can test this thing. So again, we go back to the proprioceptive system. And we go to the proprioceptive system, we can fire in sufficiently to fire the long proprioceptive reflex, not necessarily the short one. You can fire the short one, but that doesn't give you the test. You've got to fire it all the way up to the brain. You've got to get into the brachial plexus. You've got to threaten the postural ability. You can do it by just taking the ilium generally back. Or you can move the leg up and you can move the ilium posterior, anterior. Or you can move the leg down and you can go to S3. So you can be very specific as to where you're going in testing, as to which part and where the joint is involved. And I'll show you also, because then we go into Fabir. Flexion, adduction, internal rotation, in which we are pulling the ilium away from the sacrum. And when you do that, you start firing neurons. And the first thing the body does is it tries to stabilize.
That patient looks a little undernourished, Doctor.
It is. Good chiropractic patient. I've been around a lot of years. Now, as long as you've got as long as you're weight bearing, you've got the total proprioceptive system working. And it's going to react to guard. The more, and the proprioceptive system for balance doesn't just deal with the sacroiliac, and it doesn't just deal with the circle, with the eye level. It doesn't just deal with hearing. It doesn't deal just with the semicircular canals. All of these things are integrated. So if you upset one thing of the 6 things, let's say, that maintain balance. If I am just going to test one thing of 6, the other 5 are going to protect and keep that from being a positive test. You understand what I'm saying? We're going to pick up and try to make up the difference. If I can take the other ones out of play so that they're not responsible for weight bearing, and all I'm testing is weight bearing in a specific area. If I can decrease the sensory reaction in one area and increase it in another, what have I got? So let's just take a look. If we, you all know with a nerve, you know we all have a resting point. This is the nerve's resting point when you're in bed at night. And then we have a firing point where this is where the nerve reflex fires. So you have to stimulate this up to a point to where it fires and comes back down. Does that look familiar to you people? You've seen that before. Okay. So if we have somebody with a sacroiliac, here's the firing point, here's the resting point. As they're walking around all day, their nerve is up to this portion right here. It doesn't take but a little bit to fire. Matter of fact, if you're a football player or you play sports, you go out and warm up. What do? You go out and you raise the resting level of that nerve reflex so that it has only a short way to fire. So it just fires immediately. That's the idea of warming up. Matter of fact, we spoke earlier about old retired people who don't move, don't walk, don't get up and move, their firing point is way down here. How much do they have to do something to fire responses to the proprioceptive system? A long way. And we're not just talking a nerve, we're talking how many. Because as you know before, it is a multiple nerve receptor input, not just a single little one. So what things are involved in regard to this? So let's talk vision. We can talk canals, vestibular canals. What else do we have? Postural up there. Well, we can even talk the cervical, cranial, propriospinal system. But we have all of them. And while you're up, moving around, all of them are up here. They're all hanging on, they're all toned. So if I take this person and lay this person down, and now there's no neck receptor input, there's no vestibular canal input, there's no visual because I don't have to use visual to maintain balance. So the resting point comes down and relaxes. Thank you. It's got a longer way now to fire. Person's laying here in their back, what are they lying on? The thing that's in contact with the table is the PSS. So all your weight bearing is on the PSS in the pose. So at the same time we have decreased the firing level above, we've increased the sacroiliac. Matter of fact, people with an SI problem toss and turn at night. These are kids that can't sit still in class. All of us move it. You ever go to a movie theater? You see people constantly doing this. These are SI cases. They can't stand on one of them. Just fatigues out. So if we can lay them down, increase the stress on that, decrease the stress on the other proprioceptors, or proprioceptor systems, now we can specifically test one system. Okay? Got that. All right. Okay, so that's the femur. There's the fadir. Yes.
How do you know you're not getting the stimulation from the actual femoral joint? And that's,
You might be.
Okay.
You're a doctor, figure it out.
Okay.
Jesus, here we go getting the lights.
You wanted a good quality video.
Yes, okay, here's the superior ilium. Okay, below the knee, press up. Inferior ilium, press downward. Now, all of these tests, this is the test, this is category 2. PI ilium, we're testing the sartorius. And here we're testing the rectus abdominis. Oh, good. Here we go. What did I tell you? Look at this guy. How do you like that? Can you imagine that coming in your office as a 9-year-old kid? Do you think we got a problem in this SI? Look at the sclerosing. Look at this one. So these are things you start seeing. This one's got here's a sacralization on one side, not the other. Now you can see where I showed the patient how I got an inferior ilium. He hit somehow so hard that he drove the sacrum underneath the L5, as you can see over there. Now, the other thing you notice, this should be an arch. And this goes right straight down, and somewhere it looks like he may have fractured, maybe here. But he hit that so hard, bang, that he flattened out the curve in the sacrum. And when he did, he knocked the L5 forward. So you have a retrolethesis of 5. But here's a good inferior. you've got the start of a clasp knife deficiency, where you have an opening here and in the, I got a better one than this. I'll have to get an x-ray of it, a picture of it. But this L5 is restricted on motion because it slips into the sacrum there. And so you're going to probably have, and I don't remember what the lateral is, but you've got a significant loss. This is so fixed that the L4 was the one that went on the overstressing. And over here, here's a very typical S1 subluxation. Essentially, it's working towards a lumbarization of the S1 bilaterally. But you can see the stress in this SI all the way up, even up into here. Also look right here. Landed on that thing somewhere. Wow, there's a, you can see the lumbarization here, or sacralization there, it's hard to tell. Look at the torsion. Matter of fact, this is actually a lumbarization of the S1. Here's the S1. Again, look at the stress into the SIs.
How old's that patient?
Gosh. No idea. And I think that's the last one. Okay, turn the lights. All right. Okay, hope you're on your back. The left SI. What else is this? You hold this up, straighten the elbow, lift the shoulder up over the bolt. That's pretty good. So we'll take, you come up here, and we'll take it, we'll do a Faber first. And let's just see, well, that's pretty good. No pain, discomfort. Okay. So what I'm going to do is I'm going to come up to the S1, and you'll feel right here, right at the top of the sacrum. If I come down here, feel S3. So I come up specifically, go close to here, hold tight, straighten the elbow up, lift the shoulder, hold, and there's the tip. All right, hold this up, breathe in deep, hold it in, out, hold. Okay, now that turns out to be a respiratory lesion. Now of interest, it's not enough, up straight, hold tight. I'm not getting it with an arm faucet. And if I'm not mistaken, not any real bad up there. But we definitely got something going on. Now again, understand, everything's not black and white. You got shades of gray. So let's come to the S3. Hold tight. So we'll hold it in. Breathe in. Hold it in. Out. Oh, nope. So he's got a subluxation of the S3, creating enough stress into the S1 that respiratory is able to function. But there's enough stress that it's showing weakness. And I will bet you, when I come up here, when I come up to the occipital parietal suture, feel tender right here. Down here's not so much. Right there in the occipital parietal suture, here's not so much. So let's just check also, hold that up, elbow straight, push superior, hold, inferior, hold. That's pretty good. Now, well, I'll show you the inside. So I have an S3 subluxation. Up here, hold tight. Again, that's pretty good. Up here. Hold tight. Straighten elbow, up shoulder. Hold tight. See. Hold. Okay. So go up here. Hold tight. Straighten. Hold tight. Up. Hold tight. Okay, so he hit, and when he hit on this side. He drove the sacrum. Well, on this side, he pulled the sacrum apart because when we increased the lesion, no, we had a femur. So we decreased the lesion. So he drove the sacrum into that way, and when he did it, he pulled it apart here. So the whole base of this S3 is like this. You see here, I get a fadir. Up. Hold. Breathe in. Hold. I still got it. So we have an osseous component at S3 bilateral. Now, let me tell you a little goodie you can do. Yes?
Could you show for Fadir how you align the leg for S3 and S1?
Okay, in the notes that I did in my paper, I suggest that you take your hand, put your hand on the sacroiliac joint, feel the joint, and come over here. Feel where it is. Then, okay, that's there. And actually, I can feel it here, right there. Here's the S3. So you actually get, it doesn't take long, but you can put your hand back there for initially to see that that's what you're doing.
Okay, so that's for Fadir, but Fadir.
Same thing.
Same.
Put your finger in a joint, take it anywhere you want it. Just find out which way it doesn't go. You can do range of motion. With little kids, I can't get them to do the arm fossa. Now I've got a pretty good sense of touch, and I can take the ilium superior, inferior. I can grip the SIs, and I can feel where the restriction is. Because if the joint is irritated, it's going to be restricted. I can also, just by palpation, or by range of motion. See, this one doesn't go? See here. So I can even go by muscle tightness on kids. I can go by how the joint feels. Now, another little item, weight-bearing joints. Come straight. Hold tight. Hold. Navicular. Cuboid. Okay. Breathe in. Hold it. Hold. Now you like that one. Respiratory made it strong. So the effect that this is having here and on the cranium is also affecting here. What nerve root does this test?
L4.
What is this test?
L5.
What is this test? What is the, we've got S1 up here, L5. Occiput is what nerve? What Lovett relation?
Sacrum.
C1?
L5.
C4, 2, L4. If I affect a navicular, well, that's L4. Could I find a C2?
Yeah.
Or C1? It's going to affect the upper cervical spine. So when we talk patterns, We can talk neuromuscular patterns. We can talk proprioceptive sensory patterns. But the thing is, there's patterns. He could have a subluxation here. If I fix that, this may go away. This was creating the stress into the ilium, creating the stress into the suture. I might look in his mouth and check and find out he has no molars on one side. If I correct and release the stress into here from the lack of molars, I may go back down and his ankle may be strong. The main thing is you have a pattern. And that's what you want to know. And you have to work with a pattern. And if you fix 1 out of 6 things, the other 5 things recreate the pattern. All right, turn over face down, unhitch your bridges. Front. So, from here we have S1, a little bit there. More right here, here. Not as much, most of it's here, which was this side. All right, here, we have here, more than this. All right, so we have S3, 5, 4, how about right there? Amen. 5, 4, here's the 3, oh wow, that's a movement. So we got a real winner there. Come up here to 1, we don't get it. Now if I come up here, 1, 2, 3, 4, 5, 7, 6. There's the 5. Would you agree? It's not that bad. We have more on this side than this side. We have some L5, but we have a gluteal 7, which would be L3, gluteal 3, S3, and then come up here, and here's 7, right there. How about here? You can even feel the difference. Feel that rope right there. Right on 7. If I want to do segmental fixation, is L5 was fairly good, 4 is fairly good, 3, whoops, feel the restriction? Oh, look at 2. Jesus. 1's a little better, but boy, between 2 and 3, it's just like this. So L3, so we're talking C3. 1, 2, how about right there? Not as bad, mostly this guy right here. So there's a Lovett relation of this that goes to here, that goes to here. And also was this. So we're talking C6, 7, immune system, blood sugar, gonads, with the girls, this is the ovaries, urinary, chronic cystitis, bladder problems, and then you're going to end up with cranial problems. Okay, turn it back. Okay, this was the Fidere one. That one this way. Go straight. Pull. There it is. Okay, turn up on your side. Okay. I already looked at your butt. Well, look at the front. Okay, let me have the drumstick. All turkeys and drumsticks. Okay. Now this is real hard. Again, find the S3. 1, 2, 3. Here it is right there. And then get sideways and just lean. And just feel sacrum go anterior, which you place with it. Just hold it there, and then drop the body. Like that. You hear it? Watch it. Feel it. Alright. Turn the other cheek. As they say in the good book. right?
Jesus said to.
Jesus said, turn the other cheek. So on this one, we have an anterior sacrum relation to the hip. So what I'm going to do is I'm going to use this with my lever and let this guy do the work. And I'm too damn old to do this. So I'll just come over here to me a little bit more. That's it. With your heart to Jesus. Back to his mouth. Up. All right, so we get down to the S3. Number one, I'm just going to use this. You take the stress out right there. Right, the S3. So I got that. Now, when I come down to adjust and lean my body, my knee is taking in more, like that. Okay, I'm back. So, come back here and check if you wish. Up, up, up. There we go. Hold tight. Breathe in. Out. Hold. Back. Down. Just out of curiosity. Now, we haven't even done anything up top yet. Okay, let's come up here. Let's see what we got here. Hold tight. And that's pretty good. Hold tight. Again. And that's good. So by fixing the proprioception here, we didn't have to have the proprioceptive compensation down here. This released it. Check. See if he has a medial calf. Oh yes, there is some there. Am I here? Yeah, most not as bad, but there is some still there. Well, that's shit. I think it's a little late. Since that has been fixed in a position for a long time, although I'm not testing positive, I'm just going to just come in here and just get the navicular and just stimulate it. Break up any patterning that could have been in the brain with that from compensation. Okay, turn up on this side.
You fix his brain.
I think when your girlfriend tells you to turn up, you go the wrong way too. You have your drumstick. Okay. Now, normally what I do is I adjust the sacrum, but I want you to see that first. I do that and I go right to the lumbar spine. I'm not talking, remember, in the lumbar spine the joints go this way. They do not go this way. They go this way. It means they work A to P. Why try to adjust a rotational L1, 2, 3? It ain't rotational. It's jammed. So adjust inferior to superior. And so you just get in, use your body, use your leg, open. What I do is I raise the leg until I feel that open up. If I go a little further, there's the, right there, you can feel it. Once I find where that opens, that's the start of removing it. So now as I drop my body, this is going forward, taking the vertebra more posterior, as my torso is taking the body superior. Like that. Okay? You're back.
Mr. Camp,
Yes.
were you just in L3?
L1, 2, 3.
Okay.
Mobilize the whole thing.
Okay.
Well, when a nerve goes in, when you have an impulse into one nerve root area, it goes up three levels and down. You can be real specific and just get one. When I talk about the cervical spine, 1, 2, so here's right there, 3, still there, right? Say yes. Some patients are a little slow. We just get a hold of this, just relax. It doesn't have to pop and crack. I just want to take it beyond its range of motion. Just want to fire those nerves. And once I do that, we're in good shape. Okay, get up, seating still warm. Okay,
Arise and be healed.
that's right. Let's see, does anybody, Does anybody know if they have a persistent trap 3? You got persistent. Take a shirt, Jake Cook, let's just check it.
This is the zoom in and out, and everyone's just looking
That's all right. Well, just on your back, let's just see.
change for us.
Okay, I've got a situation in which I had an L5 disc and I didn't want to do surgery on it. So I went up to have them do the laser surgery, where they go in and do the laser. I didn't know that that meant they would destroy the whole joint. I thought they went into the lamina to get into the disc. And I thought, okay, that's cool, that's better than surgery. Fuse. They went in and destroyed the whole frickin' joint. Well, that's the side of the anterior S1. So now I only got one joint at L5 S1 on the right side, and an anterior S1 and no support with an L5 joint on the left side to support the S1. So that is just a constant recurrent type thing. That's bring me up. Yeah. Hold tight. And when you're doing arm fossa, up, hold. Always have the patient lift the shoulder up. As long as he's doing that, he can't cheat. Because you put it down like this, and they're going to cheat every chance they get. The more voluntary muscles you use when you fire into the proprioceptive system, and it stimulates the postural and relaxes the voluntary, the more voluntary muscles you're using, the more test you have. Up. Hold tight. Now you're pretty good shape with shaker. Up. Stay. Hold. 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 Straighten your elbow. Hold tight. See, the treat and he knows how to do it. And this is what I'm curious about. I want to find someone with this one. Come up. Up. Out. Hold tight. Holy shit. Pick your shoulder. Hold tight. Breathe in. Hold it. Shot that out. Whoa. Wait for me.
Sir.
You have this?
Up.
Hold. Okay. The S3 is okay. It's the S1. Okay. Dan, get up for a minute. Let me turn this table around so they can see what I'm doing. Yes, sir. This poor table's only 50 years old. Got it when I was a student.
It's a Lloyd table.
How old is the DECAMP table? Okay, come on, okay, bring it back. Okay, now, if you have, where you're going to find a lot of these anterior S1s is where you have a posterior rotation of L5. Because that posterior rotation of L5, what is it doing to the sacrum? It's making the sacrum go more anterior. Capisce? So the more that posterior L5 rotation presses on that sacral 1, now you're starting to push the sacral 1 anterior of the ilium. Until finally you give enough of a blast and it subluxates. And I promise you, as I told you before, that is the most weight-bearing damn joint. That is extremely important. Now, you want to be careful in adjusting because this may occur on a spondylus. It may occur on a retrolithecus. It may occur on a person like myself. As a matter of fact, I had the guy that's adjusting me. I finally realized what was screwing me up. I'd get him to adjust me, and hell, I'd be sore as hell for a couple of days. But he doesn't know how to adjust. Here's what I was showing you, I'm showing you now. He just, boom, you know, but he's the only guy I got to work with. The only guy I have to treat me. So, right here. But he's on the north side of town. But anyway, and I said, hey, wait. I said, I think what's happening is, turn over this side. If we're going to adjust something, and I'm a very specific adjuster, I'm an engineer. Now, if I have an anterior S1, anterior in relation to what? Anterior in relation to L5, PI, posterior to L5, there would be an anterior segment. Anterior in regard to the ilium. So essentially, I could come in here, and I could take this pelvis, and I can bring this posterior to the L5 and to the S1, or to the ilium. Or I can just strictly bring it there's someone on this other side. Relax. Now, we still got this one. Still got something like this. Pick this up. All right, so any restriction over here, this won't go. Bring this up. Hold tight. Breathe in. Hold. Still there. Relax your foot. Relax your back. There it goes. Do you see the improvement? It's not all out. There's something else going on in here. Such a beast. Hey, I'm going to push you in. You hold out. Hold tight. Now. Come up here. Hold tight. Your foot bend in your elbow. Hold tight. That's what I thought. Trying to cheat every time they can. So relax for me. Okay, now let's see here. Aha. Relax. I think that's a little better. Now let's come up and relax. Come up here. 1, 2. Relax. Relax. Down here to 5. 1, 2, 3, 4, and there's the 5 right there. Yes? See? There's the 5 that goes along with the S1s. Relax. Now I know what. Turn on this way. Do the lumbars. I'm ahead of myself.
Making it work.
I know. Oh, look at there. There. Yeah, just adjusting the lumbars took a lot of it out of here. Now maybe it will adjust. Relax.
hang on.
Well, we still got some. Breathe. Again. Bend over.
Oh, no.
Check your prostate over.
Are those flavored?
Oh, they are. I'll tell you, you'll love this one. Yeah, you always carry finger cuts with you. You never know when you gotta check somebody's prostate. Work.
That's not true used, is it?
Well, not lately.
He's gonna go through your mouth to your prostate.
That's right.
By way of the globus pallidus?
Yes.
You want a glove, Nelson?
Huh?
You've got a vinyl glove if you want it.
Did you pull that out of your wallet?
Well, you know that trick, do you?
Wrapped in foil?
It got too overheated, is what it
Here's a
is.
glove.
No, I carry finger cups with me. Matter of fact, I've got one. I might even have a glove. But
Here's a
usually
glove.
I just.
Yeah, no worries.
But I do because I always end up fixing somebody's damn it. So. Jesus, this is good for you.
Oh, you know.
Howie Mandel.
Yeah.
What size is that back there?
Large.
Close.
Oh,
Did you agree?
they didn't ask that, man.
Oh, thank you.
Lysosutural.
Yeah, go.
That's what I was gonna say.
Oh, it's hard on people. Breathe in. Breathe out. Yes. In. Okay. Now. It's getting better, but we still got something on the left side. Oh, yeah. But, anyway, can you see how you work within a pattern? And that's what I want you to understand. I want you to be able to, you know, if what you're doing routinely with the patient every day and doing the job, then you better figure something else out. At least you now have a direction in which you can think. All things are not easy. All patients don't read the book before they came in to know what they're supposed to have. So you've just got to sit, and just like here, you got to work from end to end to end to end. Now, this seems like it takes a lot of time. Now, people say, well, SOT takes a lot of time. No, it doesn't. Believe me, my brain is working. Now, let me say this. It's going to take a while for you to be able to ingrain these patterns in your brain. You have to work various complicated. It's just like getting a video game. The more you play it, the faster you get, the better you're able to do it, right? And that's the same thing here. This is just another video game. And the more you start interrelating these things, you just start, boom, you already know where to go. You can just go check them. Boom, it's there, fix it, bang, up, out, and go the door. So it doesn't. It's actually faster. It may take a little more time than the guy adjusting everything from Atlas to rectum. But that patient isn't going to be there very long because he's not getting better. Your patient knows that you took the time and they're going to stick with you until you get them better. So that increases your practice. Okay, you can get up. You can see you can still walk. What I'd like for you to do is I would like for you to take a few minutes and do this testing, if you would, while you've got me here. You can put a couple of chairs together, whatever. I'd like for you to be able to experiment and know that it works or doesn't work.
Can you review the indicators, the bar and the dip?
Review the indicator. Category 2.
Yeah.
Stick with it.
Yep.
One neck tighter than the other, one side of the neck tighter, paraspinal maybe. You're finding differences within gluteal sacral indicators as well as the gluteal lumbar indicators. It's not tying in. You've got, primarily if you get any S1, 2, 3 indicators, check for the gluteal indication and it'll relate to which one it is also. Go up to the lumbars, you can check that, go to the trap, you can check it back again, turn the patient over, stress that joint, whether it's the S1 or the S3 area. Fire that receptor. Now you've got to fire the receptor. That doesn't mean you got to torque the bloody leg off. But it does mean that you have to put a sufficient stress in to where you're going to fire it. And it's not going to create pain. So I would like, any of you that are interested, please come up, pull some chairs together, do whatever you can. I would like for you to experiment with a bear or deer. If you want to do superior, inferior, go for it. But I want you to experiment with taking the ilium, half of the SI joint, into its whatever range of motion that it can go. Superior, inferior, torsion, anterior, posterior. It doesn't matter as long as when you fire into that proprioceptive system and you fire sufficiently enough, it's going to contract the postural muscles and it's going to relax the voluntary muscles, which is your arm test. So go. Whoever wants to try it. Right chair. Hold tight. Relax. Hold. Down. You're doing pretty good. Down. Up. Hold tight. Back. Hold. Straight. Hold. Okay. Now I want to show you. Now that's an immediate test. It takes time for the postural system to strengthen and to allow the voluntary system to come back strong. And also for the cervical cranial proprioceptive system. And I'm finding it takes about 4 seconds. If I do, hold tight, see this is what, you get, let me get some of this. Come on over. Now you're fighting me too hard. I can get enough information, but I don't get the demonstration. Watch this. Up. Hold tight.
Mike?
Lift the shoulder. Hold tight. There. Okay, now, that was doing an immediate test. Now, if I stimulate for 4 seconds, 1001, 1002, 1003, hold, it's strong. If I go to 2 seconds, 1001, hold, it's weak. Go to 3. 1001, 1002, hold, and kind of betwixt and between. So between 2 and 4 seconds, the voluntary muscles are starting to come back. So Mary, you stimulated down here, and then you went to test. You waited too long. Come down here, fire, hold, and test.
Okay.
You did this, and then you took your time coming up here. By that time, the whole system is back. So you have to do it. You have to, when you're going to do it, test it, go. Now understand, depending on how bad that is, it may only take a second for it to bounce. It may not be that big a deal. But basically what I've found, it takes about 3 to 4 seconds. And then the postural system relaxes and the voluntary muscle comes back. So you can't dilly-dally. You get there, do it. And when you're going to test something, up, hold tight. Relax. So where was that? Hold tight. Oh, straighten up, no, hold tight, whoa. Okay, good luck. Okay. All right, so I just say, when you do it, do the test. The longer you wait, the more you might lose the positivity of the test. Capiche? Okay. Go back to the head, test it again.